Later. Hey, I'm so sorry I ran back to the dorms. Oh, it's. Yeah, or like later today, then let me get your number. I'm so sorry, I didn't mean to blow you off. I was like, oh, I'm gonna text, let her know. I'm like, but I have to like lay down. Like,
It's already 1:15.
yeah, no. You think it like gets better? It does. Yeah, you don't get more tired and have to like. Yeah, I had to go lay down there. You're not doing that with my nerve. I needed to like pick myself up. Yeah. I have really bad. Yeah. Yeah.
Free flow. I don't even think they're gonna.
And like, you know, I think I need to like here. I know. I can.
Yeah, I know it's younger. But that's what they have.
Yeah.
But no one's gonna do.
But I think I actually started. I started my. I love that. That place. So and I also like club. Now, so like week before. But I got up to like one. That's stuck out.
That's all we have in this.
Yeah. I couldn't really go out of the week. So, and I was like, now, so I decided I needed to. I'm close to that. Where do you go? Yeah. Yeah.
Not here, I mean.
Oh, okay.
You don't remember?
No, but I do know I was in the class personally, so I actually felt like love. Yeah.
They sent us, email with it, so I printed it out myself.
First aid, like.
Yeah, so I have.
Okay.
To them. So
Yeah,
I had a hard
I was
copy of it,
screenshot.
always like.
I was gonna bring my Facebook, but it's like too big.
Oh, yeah, yeah, and it's pretty. Just brought all my PDFs on my iPad.
Yeah.
Too, and,
How do you usually take notes during today?
I like write in my notebook, like I don't write directly on the thing, so I want, like, I write down what I don't know.
Yeah.
I just want it all.
That makes sense.
Yeah, so I can do like, you know, a quick review.
Have you been going over the PDs?
What's my review here and there? I do,
Maybe, I don't know if I'm working with them, but some people invite us to the grill at 4, so either we can do them or.
so yeah, it's up to you.
Maybe now join them and see if it's like helpful and. I try to keep my.
Okay, perfect. Yeah, after.
Yeah, I'll be
After
here.
with
So,
you.
yeah, I think I'll be better in like a couple hours. I just like really like,
No, it's one of those things, but the beginning is we have to get acclimated.
and I feel like everybody else here is already like acclimated. So
There's a big difference. Between-
Yeah.
we're over-
you think it gets harder? Or higher?
I'm always so busy, like,
Yeah.
people to do.
What do you do like after class?
Like after, well, I had like meetings for like job work or my computer, whatever. I do like a lot of things.
you have like an MVP.
Yeah. So.
You have a lot of.
I have like a meeting. 5 p.m. So it's not-
Yeah.
It's like global stuff. Like I try to put that stuff, but on top of it, five thousand or 2 weeks like that.
Are you enrolled? Okay.
It's like for. So
You
like.
already,
I'm
like,
graduating, other than notes, like second one, like time. Yeah, I did not. I'm going to.
Okay, yeah, you like talking time on.
Yeah.
Yeah.
Yeah, it's because they know like all of the stuff that I talk about. Like, you can drive, you know.
Like, let's see your name. Everybody, and I was like, I can't.
Because they don't want to be considered for years.
Well, I mean, I was gonna say, I was step one. What they rather have step one.
Yeah, and I can hear clinical college. Like, it's really strict, like they're.
Yeah. They're definitely not like health. Yeah, I went to UCLA for my graduate.
Yeah, they're pretty.
Where did you go to? Yeah. Must be
I think this is like. Just like very.
Yeah.
It's like, very rural, but.
At
It's
least
like
there's,
not.
like-
School. I don't know. Yeah. I was already.
We're not into Florida, we're like not established yet and we're gonna.
I've been to school before, they're non-college, except for University of Miami.
Yeah, I got
Yeah.
into like SAU.
Yeah.
Now they're.
So how are you like? Your method.
What do you have?
I personally had a L. I failed two classes this year. They all-
Really? Did you fail like twice? Did you like fail? the final one?
Well, I failed the.
What was it?
So I could only.
What is it?
What are you doing all and then I just. Probably before those classes, I want.
Oh, no.
And I had to.
It's an egg one.
Oh, do you know who you feel? This girl. Yeah.
Well, I
So at least you have me with that.
And I went.
Everything now is in the school, right?
Right. So now I. settled it.
It's a fun.
I was in the car.
Oh, you were in the car.
Yeah, that's the car. Like,
Is your airbag before?
the airbag is. I wanted to go to the doctor, so like, and then all the bones were shattered, not just broken, so we had to spend 7 hours. Pattern. That like. class reading, that's an important.
So is it okay now?
I still have phone driving, that they should like, it's all metal, so.
Yeah, driving is really dangerous.
And then drive for everyone.
It's supposed to. Oh, it's the angle.
Yeah, I like it.
Thanks for sharing.
Yeah, I feel like that was a lot I just put on you.
Yeah, that's okay. Anytime.
So, yeah, but yeah, so my medical school was like rough.
Yeah.
Where's Red Castle? It's all.
So like. Oh. I don't know.
Try to learn how to explode.
Yeah, just like. I did. Other than that, I didn't put my bag. Yeah. Finished workout. Sounds like no,
This is.
yeah, I just wanted to.
Oh, this one.
Yeah. Yeah.
I remember it. I spent the past week trying to. What was her name? Oh, she does a really cool, like this. She's keep going like.
Oh.
Yeah, I was listening, but I was wondering.
We're too busy. I think it's tree. Oh, oh, she has tomorrow. Okay. I took on Sunday. I just scheduled for Wednesday was enough. You know.
My mind is like. I want to see you read about.
You know, with pyramids.
All right, let's roll. Yes, ma'am. Question is? Most books are for CPS too. For you said rating me step for what pathway again? Permitting, yeah. Most books will say CPS too. Some of the new guys will argue. I told you the new guys argue about everything. Yeah, but on the test, I've never seen the answer change. So I'll still stay with CPS too. Yeah, so on the test, just make CPS too. All right, let's see. We got a couple of birthdays we got to celebrate. We got Chris with a K, birthday today. Yay! And then I heard Montessori had a birthday, what, yesterday? All right, that means we gotta sing, folks. We'll never make it to American Idol, but we're gonna try it. We're gonna sing. All right, everybody online, we're gonna sing happy birthday. Just make it generic at the end for the names, all right? But just so, you know, when they say, what's that? Yeah, to you all, yeah, like that. Let's do it that way. All right, on the count of 3. 1, 2, 3. Happy
Happy
birthday
birthday
to
to
you.
you.
Birthday.
Happy
to
birthday
you.
to
Happy
you.
birthday to
To
you.
you.
Happy
And
birthday
to
to
you.
you. Why are you happy?
What?
You're so happy.
Why are we happy?
Why are you excited? You.
Me, myself?
Yes.
I'm excited every day, girl. You know that. I'm excited every day to see you, even though I don't see you. I'm excited to hear your voice, even though you don't know when your mic is on.
Please, I have a question, please.
Yes, you have a question, please go
Please,
ahead.
what's the difference between a left and right heart failure?
Oh, well, that's coming up in cardiac in a couple of days. Let me save it for that. That way I can discuss the whole thing for you.
Okay, sir.
Yeah, rather than branching off right now. All right, let's go. Finish it up. Let's go. Here we go. So we were on we did monosomy. Patau is the only monosomy you need to know. And now the trisomies. All right, trisomies. I'm sorry. Turner syndrome is the only monosomy you need to know. Trisomies, again, because you mess with chromosomes, they're gonna die. The majority will die. Okay, there's only 3 that live to see you in the office. And 13 and 18 live only a few months, and most of them die. Although I did hear about one that lived into his early 20s. That's not the norm. That's why I say I hate to talk about rare things with you guys. And so somebody remember on data exam, start picking that stuff. Okay, most Patau and Edwards die in 3 to 4 months. They don't even see their first birthday. Okay, so Downs is the only one that lives a normal life. That's the one we're going to spend the most time on because there's a lot of questions about Downs. So let's do it. So most common cause of all of them, again, is non-disjunction. That does not change. More common in meiosis I of mom. That does not change either. But how do I know you got Patau's? Series of P's. So since Patau's begins with P, I just turned them all into P's. Polydactyly, you got extra fingers. What if they ask you, I said, this kid's got 7 fingers on one hand. How come the other 2 fingers didn't dissolve? What failed to happen? It probably doesn't happen. Look at that. We're ready to answer all these questions now. See, don't have to do any extra reading. All right, now how do you handle polydactyly? First thing we do, feel for a bone. If there's a bone in there, that finger works. If there's a bone in there, the finger works. No bone, tie a suture, cut off his blood supply, it'll necrose and fall right off. All right, so if there's no bone, we don't even send it to orthopedic surgeon. I tied him off and it'll turn black and blue and falls right off. All right, because it doesn't do anything anyway. If there's a bone, that's an orthopedic surgeon problem. It has to be sawed off properly. So that means you send it to orthopedic surgeon, and what does he do next? He asks mom, do you want him to keep this finger or not? They always give that option. Just so you know, they always ask that, mom, do you want him to keep that finger or not? Because if she says yes, don't do anything. All right, because you know, these days they got texting contests at the end of the year. Maybe if you got 3 thumbs, you're gonna beat everybody else, right? So mom may want him to keep that extra thumb on there. All right, but I've never seen a parent say yes, because you know the kids are gonna make fun of your kid, and in school for the rest of his life. You don't want to do that to your child. That's trauma. Yeah, so they always say, no, take it off. And so that's why they'll be saying when they saw it off, okay? So that's how you handle polydactyly of any type. Palate, P, palate is high arch. Rather than nice and flat like that, is arch, that's extra palate. Notice the pattern I'm using. You have an extra chromosome, I expect something extra to be present. Everybody see my pattern? All right, just so you know, I don't try to memorize this stuff, because you know, when you get to the test, they got some other words to play with you. All right, as long as it fits the pattern, you say, yeah, why not? Doesn't matter if you never read it, just say yes anyway. All right, so palate is high arch. Peeing symptom abnormality. You know, I didn't want to say GU, but it's GU. Since I make it P's, let's make it P. Peeing. All right, now, years ago, I wanted to make sure I'm teaching you the right stuff, because I made a pattern, but I never looked it up. As I just assumed I'm correct because I knew the pattern. So one day I said, okay, let me look up this renal problem that Pataus had. When I looked it up, look what it said. Duplication of the ureter, most common. You see that? Extra tissue. That means even if I never seen that before and they were doing the test, I would have picked it anyway, because that's my pattern. Extra chromosome, extra tissue. That means whatever you want to call it after that, I would say, yeah, why not? That's what I mean by don't debate details, because no book has every detail in it. The test route always knows more details than you've ever read about. Okay, and that's what he plays with. And students keep trying to figure out every detail, and then all of a sudden they say, no, it can't be that disease. Well, he's got you now. He convinced you of something else. Okay, anyway, so peeing system abnormality, and then protruding belly, that's omphalocele. They always ask you to compare and contrast omphalocele versus gastroschisis. So let me do it right here. Oh, I forgot I have it on the next slide, sorry. Let's just do it right here. So omphalocele, first of all, involves umbilical opening. Gastroschisis does not. Just a mere mention of that, I get my point. They either say umbilicus or they don't say umbilicus. That's it. That alone will get you the point, okay? However, omphalocele involves the midgut. You guys remember the midgut is the only one part of the GI tract that develops out in the yolk sac. So when you have omphalocele, only the midgut can be popped out. It cannot be any other piece of intestine. And it has a sticky covering of the yolk sac, because yolk sac covers up whatever develops in the yolk sac. Okay, so that gooey tissue. Omphaloceles have it. Gastroschisis does not involve the umbilicus. It is a hole in the abdominal wall and some intestine squirted out of there. So it can be any part of the intestine. So there's no particular part, and there's no sticky covering. So they will give you the clues, folks. The key is you just gotta know what the clues tell you about which one it is. What do you do with these things? All right. First thing you do, put sterile towels on it. Either one of these, put sterile towels over it. Why? That's peritonitis waiting to happen. Remember, there's germs in the delivery room. You don't want to wait till this thing is infected. That's a surgical emergency, and the child, so many children will die. That's why you cover with sterile towels immediately. Call the surgeon. And then he will take the child straight to surgery and build what we call a silo. A silo is going to take, it's kind of a mesh, all right, and put it over the intestines. That protects it. And then they squeeze a little bit in. When you squeeze a little bit in, the muscles will start to stretch out and allow it to come on in. And then about 2 weeks later, you squeeze some more in, and you just do it in increments. So it takes about 5-6 surgeries to get it all in there. But muscle stretches, like for anybody else, and the child will be just fine. Because if you just squeeze it all in there, intestine will just be compressed, blood supply is lost. It would infarct the whole thing. So we never do that. Those are 3 steps. Any questions on these 3? Or these 2 rather. There's 3 steps, but managing 2 things. All right, trisomy 18, Edwards syndrome. The rocker bottom feet, 95% of them have it. And then triphalangeal thumb. That means 3-leaf clover thumb. And they'll tell you it overlaps all the way out to the pinky. That's how much extra thumb that they have. Keep it in context with our pattern of extra tissue. Yes. Oh, good question. How does umbilical hernia differentiate from omphalocele? Umbilical hernia has skin over it. Yeah, umbilicus definitely has no skin over it. Yeah, good question, because I did see that one time.
Yeah.
Yeah, that was the clue. Yeah, skin or no skin.
And then gastroschisis.
gastric schisis just is a hole in the abdominal wall. Could be anywhere else.
So they
Not-
have no skin.
They have no skin over it either. Nope. All right, so where are we? So Edwards syndrome, triphalangeal thumb. Anybody remember another syndrome with the triphalangeal thumb that you learned? All right, Cynthia remembers. Yeah, diamond black fan. So it means the two of them have the same genetic problem, but we don't know what the genetic problem even is. Matt, question. Huh? Double thumb? No, just three-leaf clover thumb. No, there's no double thumb that I know. That'll just be, polydactyly. All right, so that's Edwards syndrome. And then Down syndrome is the one that lives the longest, so we're gonna talk a little bit about him. Most common cause, hang on, still non-disjunction, that has not changed. And meiosis one of mom, that has not changed. Remember I said most Down syndrome children are born to young women. Why? Because they have more children than older women. So that older woman answer has never been right, no matter how you try to slice it. Be careful, because I still see that trick always on the answer list. That's how I know that they think students still have not figured out the difference in the statements. Because they still think older woman is the number one reason for Down syndrome, and it's not. Okay? Anyway, if you have 2 or more children with Downs in the same family, then pick Robertsonian translocation. Because Robertsonian translocation, 1/3 of your children will have Downs. It'd be hard to have 2 non-disjunctions occur back to back in mom. So Down syndrome is a lot of things to consider, so we're gonna consider them one at a time. Victoria, you have a question first.
Is maternal age still a factor, even though it's not the most common?
Maternal
Does it
age
still
is a
cause it?
factor.
Okay,
It
it's
is
just
a
not the most
factor
common.
insofar as, remember, the longer you live, the greater chance any chromosomal problem will occur.
Okay, okay.
Yeah,
okay.
not, that's true for every disease, just so you know. Yeah, it's not unique at all. And who had, Zena? Microphthalmia, small eyes? No, in Patals? Around it?
The micro versus like between.
Microphthalmia means small eyes. What's the other one? Micronathia means smaller jaw. Yeah, that's it. Yeah, but again, it's the P's that make the diagnosis, just so you know. Small eyes and small jaw can occur with a lot of syndromes. That's why I don't even use those. Notice I didn't even mention it on here. All right, where are we? Down syndrome, here we go. Oh, boy, here's another slide I gotta update, all right? So forgive me if anybody gets insulted. You know, intellectual disability is a term that they want to be used all the time now. So it's 100% risk. 100%, because you mess with the chromosomes, the brain is not gonna form properly. So you've got 100% risk of intellectual disability. IQ. Average IQ in America. This is only for America, because anytime you do IQ testing, it's only for whatever population you're studying. Average is 85 to 100. With a standard deviation of 15. One standard deviation is what percentage of the population, Lillian? And Nolan. 68%. That means 32% are outside that. 16 on the high, 16 on the low. 2 standard deviations, what percentage of population, Amy? One is already 68. 2 can't be 30. You gotta be higher than 68. Let me ask Reed. Is it 94 or is it 95? It's 95. And remember, we already said that before. So 1 is 68, 2 is 95, 3 is 99. All right, 3 is 99.6, sorry. All right, so average IQ in America, 85 to 100, deviation is 15. Then if you talk about superior intelligence, anytime you say superior, that means you're outside of 2 standard deviations. Well, add 30 to 100, that's how they got that 130. See, again, once you know how these calculations are made, you don't have to write down these numbers. That way you already know the pattern of how to derive the numbers anytime you want. All right, and then from 85, the lowest normal, you just start subtracting 15, see? So mild, under 70, moderate, under 55, severe, under 40, and profound, under 25. The profound is the one they like to ask about the most. Why? Because they cannot take care of themselves. They cannot do any activity of daily living, ADLs as we call them. That means they have to have 24-hour care. So as a pediatrician, if you got a stay-at-home mom, no problem. I can discharge that child at home because mom's gonna take care of him. But if mom works and dad works, guess what? I cannot discharge that child. So you show me how you're gonna take care of this child. That means they hire a nanny, or we arrange for a home health. Somebody's gonna be there all the time. Because this child can light himself on fire, won't even know what he's done. Okay, and we'll all be liable. Okay, so that means I have to be sure that somebody can take care of the child when he or she goes home. Okay, now let's look at many other things that you see. Now, most Down syndrome, we said it's 100%, but most of them have mild to moderate. Okay, and that's why you can teach them a few things, but the severe ones, you can't teach them anything. If ever you've been at Walmart, some stores, remember they're the greeters. You can teach them how to just say a line. Welcome to Walmart. Okay, when we have them, I know the hospital I was working at, they have them greet at the door at the hospital. Welcome to St. Francis. Okay, at the cafeteria, you can train them to take the trays off the table. Okay, it's got to be some simple activity that they can learn quickly. If you give them an activity that takes 7 steps, they're not going to remember. Okay, all right. Other things seen in Downs. Early onset Alzheimer's. How do we get this? We've talked about it before. In the general population, remember, beta lipoprotein E4 is the one you see in the general population. Because it's such a tiny particle, you don't see it till like 8, 60, 70, 80, then you see Alzheimer's. But in Alzheimer's, early onset Alzheimer's, what we see, this lipoprotein is actually a breakdown product of a bigger one called amyloid precursor protein, or APP. In Down syndrome, they cannot break that. So you got a larger particle getting stuck to your brain, and therefore, Helima, it takes up more room, and therefore you get the Alzheimer's much earlier in life. So anytime you see somebody with Alzheimer's in their 30s or 40s, the person is Downs. What if you look at them, Andrews, but they look normal? I'm telling you, they're Downs. How's that possible? You look normal, but you got something seen only in Downs. What's that? No, variable expression is only for autosomal dominant. It's called mosaicism. Remember, it means the cells already divided, and some of them became trisomy 21. The others stayed normal. That's why you see a little bit of both. Okay. All right. So always think Down syndrome. Anytime you see early Alzheimer's, it doesn't occur in any other disease that we know of.
That's the phenotype is not the same.
The disease is manifesting earlier because you got a larger molecule. That means it takes up more room, and therefore you get the disease quicker. Now, what has to happen for that thing to stick to your brain? It needs to get oxidized. So Zena, what's the #1 reason for free radicals in your body? She forgot, Sabu. Infection with what? With viruses. The cells who make the free radicals? Neutrophils use what enzyme? I know you knew this. Take a few deep breaths. The enzyme that they use. See if it help you. NADPH oxidase. And NADPH oxidase, how is that inherited as a deficiency? So who says? Yeah, well, it's one of the X-linked recessive enzymes. It's one of them. Is that right? But that means if that's one of the 10, that means there's 9 more. That means either I got 9 nervous people right now. So let's split it up. I want 2. Gloria, just give me 3. Start me off. Adrenoleukodystrophy, CAT1. G6PD. OTC, that's 3. All right. No, wait a minute. We're gonna share the pain. All right. And 9. Give me. Too much cortisol. Sandeep. Adenosine deaminase, IL-2, IL-7 receptor defect. All right, that's 4. PRPV synthetase, 5. Hunters. Hydrogenase, 6. Matt. Give me 3 more. Fabry's after galactosidase, 7. That's 9. ACPRT, 8. Well, this is 1 right here, so we We already said NADPH oxidase, CGD. So there's only one more left. You know the last one? All right, Gloria, finish it up for us. Tyrosine kinase, like croutons. Very good. All right, at least it's getting easier and easier. All right, so in Alzheimer's, free radicals have to damage these the life of these amyloid, and then they get stuck to your brain. Okay, so that's why you need to eat up the free radicals. How do I eat up free radicals, Gustavo, from your GI tract? Vitamin C from your bloodstream. Vitamin E. Remember, I told you vitamin E slows down the progression of Alzheimer's. And what is the first line drug for treatment of Alzheimer's? Ajni. And Cynthia. You're thinking about rivastigmine, which is being used, but it's not first line. All right. Oh, that's good. She said it. Donepezil. Remember, most common, donepezil is first line on any test question. That's first line. Rivastigmine is an old drug they brought back. Rivastigmine. And then galantamine. Remember, those are three that they're being used right now. If you remember, memantine blocks glutamate. So you're blocking an inhibitory signal so that the stimulatory signal stay more prominent. They got a donepezil memantine combination. So it's after donepezil kind of flattens out, then you add memantine, then they get better again. All right. So anyway, higher frequency of AML, but ALL is the most common leukemia. Why? Because ALL is the most common leukemia in all children. Common and frequent are not the same question. So let me illustrate what that means. Let's say I have 100 children with cancer, and 98 of them have ALL. That's why we say ALL is the most common cancer in children. Everybody understand that? And all those children have a lot of different diseases. I say, well, how many have AML? 2, the remaining 2. That's why AML is seen in 2%. Everybody with me so far? Okay, then I say, well, how many children have Down syndrome? You say 5. Okay, have them 5, step forward. So the 5 step forward. That's well, how many of them have AML? The same 2 I pointed out before, except now 2 out of 5 is 40%. See that? It looks like a higher percentage. That's a higher frequency, but it's not the most common. Because even with those 5, 3 of them have ALL. ALL is still the most common. So any question that's asked most common, folks, don't read the vignette. You're wasting your time. Okay? You're supposed to already know the answer without the vignette. If you read the vignette, you're just playing with fate. All right? But the test writer is going to fool you into thinking you ought to change your answer. Okay? So most common does not require a vignette ever. It's just something you're supposed to know. That's why we drill it in class all the time. Most common for everything. I give it to you guys. Okay? All right, 20 to 40% have congenital heart disease. So echocardiogram is done on all Down syndrome children for that reason. You understand, Adam? I know Adam's still under the weather. You there, Adam?
Yes, sir, I'm here.
All right, my man. All right, hang in there, bro. Lots of liquids, man. Hot liquids. All right. So hopefully you get better in the next few days. All right, so anyway, that's why we're doing echocardiogram on all Down syndrome children. Because 20, 40%, you don't want to miss. They're going to have a heart disease and you want to know which one it is. The most common heart disease is seen in Down syndrome. Look at that. Endocardial cushion defects. It turns out Down syndrome has a problem with, neural crest migration. You guys remember endocardial cushion has to do with neural crest. The spiral membrane is neural crest. So what do we see in Down syndrome? Endocardial cushion defects, number 1. Then VSD and ASD together, number 2. VSD by itself, number 3. And ASD itself, number 4. Now you can write it down because Dr. Francis put it down on the slide, or you can try to understand how we got there. Okay, fine. I want to understand how we got there. All right, wait a minute. Okay, this is the drugs we just talked about. And the donepezil still being used first. All right, problems with neural crest migration. So the spiral membrane is what's involved. But this also explains to you why they have Hirschsprungs as a problem. But we'll talk about that later. Okay. And I thought I had a picture for you guys. Let me, no. Wait a minute. No. All right, that means I'm gonna have to draw it for you. I thought I had a picture, but I don't. All right, let's see. Let me go back here for a second. All right, endocardial cushion. All right, so everybody follow this. Let's see. You've got endocardial cushion right here in the middle. You got, let's make it blue. So you got atrial septum. Septum, secundum comes up from the endocardial cushion. Okay,
Oh, you do have to.
Oh, geez, did I move it? Oh, that means somebody got moved. Hang on. Is it further ahead?
Yeah.
Ah, maybe I accidentally moved it further ahead. That's what happened. Yeah, okay, that's my bad. That means when I was rearranging this thing, I put it too far ahead. Yeah, so it should have been, all right, let's go ahead and I'll go back. All right, so endocardial cushions, the first thing that develops, let me see who's gonna help me out on this one. Let me pick somebody online for this. Mabel. Mabel, are you there?
No, I'm not there.
This session, man. Oh, man, you're too funny. I remember follow me on this. Okay. You have endocardial cushion. Everybody picture with me. The top is the atrium. Everybody understand? The bottom down here is the ventricle. What happens first? Septum primum comes down first. Remember, premier, the top guy. So he's got the longest distance, come all the way down to that endocardial cushion. You understand, Mabel?
Yes,
All
sir.
right, good. So septum primum has the longest distance to come all the way down to the endocardial cushion. After that, septum secundum comes up from the endocardial cushion and then boom, seals off this hole. Until they seal this hole, this is called your foramen ovale, just so you know what that is. Okay, the space between primum and secundum, foramen ovale, until you close it off. You understand, Mabel?
Ah.
All right, because primum, premier, has to travel a longer distance, that's why he is the most common cause of an atrial septal defect. Does that make sense to everybody? 90% of ASD is a septum primum problem. It just didn't make it all the way down. Why? Because we delivered the baby earlier. That's it. You delivered the baby prematurely, well, the primum didn't come all the way down yet. You're stuck with an ASD now. Classic clue for ASDs, fixed wide splitting of S2. We'll talk about that more in cardiac. But that's how you make the diagnosis, easily. Fixed wide splitting of S2. Now, in Down syndrome, they don't have an endocardial cushion, like I just said. If they have no endocardial cushion, there's no septum secundum either. So the most common cause of an ASD in Down syndrome is septum secundum. See? So you got to be careful. I asked about ASDs in the general population, then I pick septum primum defect. But if you say Downs, then it's septum secundum problem. Any questions on that? You understand that, Mabel?
Yes, sir. Yes, sir.
All right. So one more time. Septum primum comes down first. Septum secundum comes up second. Then after that, ventricular septum comes up last. So ventricular septum comes up from the bottom of the ventricles, climbs all the way up to touch the endocardial cushion. Everybody clear? You understand, Karis? That means if the baby is born prematurely, Mabel, which one is likely to still not have happened yet? Septum primum, septum secundum, or ventricular septum? The one that happens first, second, or last?
Septum primum, sir.
No. Septum primum occurs first. So if you deliver a baby early, the event that may not have occurred is the one that occurs last. Right, follow? Because he didn't stay in utero long enough for the last thing to occur.
Okay.
You understand that, Amy? You understand that, Karis? You understand that, Chris? That's why VSD is the most common congenital heart disease. Now, everybody reads that, highlights it yellow, purple, blue. I've seen every color in the world. But look what happens when you go back and reread normal, like Dr. Shah made me do. And all of a sudden, oh my God, this makes sense. I told you the most common abnormal is normal. When I used to say it that way, people thought I was crazy. What do you mean the most common abnormal is normal? That's because you don't know. That's the game they're playing. The most common abnormal is what is normal. And somehow you interfered with it. And then boom, you stuck with it. Okay, simply because it just didn't come all the way up, and then the baby was delivered at 35 weeks, 36 weeks. Well, septum didn't make it all the way. All right. All right, any questions on that? Now, look at the 4 diseases seen in Down syndrome. No endocardial cushion. See that? Common AV canal. That's why that's number 1. Spiral membrane is supposed to come down through the septum and touch the endocardial cushion. So that's why it never developed, because there was no spiral membrane. Remember, lack of neurocraft. All right, what if a little endocardial cushion developed? Now you got an ASD at the top, VSD at the bottom. That's why that's number 2. It didn't fully develop. And then VSD is more common than ASD. And look at that. As it rounds up number 3 and 4. Without guessing. The key is you gotta go back and relearn normal first, then you see where they got their list from. And see, once I understood where they got the list from, it means I don't have to look it up anymore. That means you can look in your own mind and recreate the list again. All right? Steve?
So our Down syndrome babies more likely to be premature?
Down syndrome babies are more likely to be premature because of hypothyroidism makes them so big that they deliver early.
That's why the VSD is more common. than the
That's why VSD is more common than ASD, correct? Yes, Solange.
In what instances would atrium be the problem?
In what instance would the atrial septum be the problem? That means a baby who's really born real early, like 24 weeks. We deliver as early as 24 weeks. Well, that means none of this has happened. That means that even the first event has not occurred yet. Yeah, but they'll also have a VSD because that hasn't occurred either. Yeah. Huh. Anders? The last 3 lines of what? These over here? Yeah, I said, in the first instance, there's no endocardial cushion because spiral membrane never made contact with it. And that's why they call it common AV canal. That means pink and blue blood sloshing around anywhere it wants to go. Okay? The second one is spiral membrane touched endocardial cushion a little bit. That's why it developed a little bit. So that means it didn't take up the whole space. So now you got a hole up here and a hole down here. That's why ASD and VSD together is the second most common heart disease. And then VSD is more common than ASD, so it rounds up 3 and 4. Okay, because prematurity. All right. Let's go back and I'll pick up the rest of the discussion. All right. So cyanotic heart disease and Down syndrome, because Down syndrome has nothing to do with cyanosis. That's why it's the same as everybody else. Down syndrome, trisomies have nothing to do with cyanosis. How many grams of hemoglobin, Ashley, must be desaturated for you to turn blue? Let's see if Hendrik remembers it.
5 gram.
Yeah, 5 grams, no matter what your hemoglobin is. 5 grams have to be fully desaturated to 0, and then you turn blue. That means central cyanosis. Remember, purple cyanosis can happen just when you're dehydrated. So that's not what we're talking about. All right, if you're blue, Down syndrome, this is any child born blue. Transposition grade arteries is number 1. Why is that? Because simply, spiral membrane is supposed to come down in the 3rd trimester. Your aorta starts off on the right, pulmonary on the left, and when the spiral membrane comes, they switch places like this. So your aorta is on the left, pulmonary is on the right. That means if we deliver a baby early, you never had this happen. That's why it's the most common. Look at that again. The most common abnormal is what's normal. All of us in this room start off with transposition. Okay, but you stayed in mom long enough that you actually spun around and the aorta went to the left. But if a baby was delivered early, didn't have time to spin to the left. You're stuck with your transposition. And then second, Tetralogy Fallot. Means the spiral membrane came and then spun too far in to the right side. So then you have overriding aorta. And that's what starts the problem. So these 2 T's are the top 2 cyanotic heart diseases in all newborns. All newborns, without exception. So they ask you about cyanosis and newborn. That's your top 2 in that order. Which means you have a right to left shunt. Blue blood is going to the left. Which means you need to correct it with a left to right shunt. That's called a foramen valve, but that closed already. That means PDA is the only other way to correct it. That's why they have to have a PDA stay open. Everybody understand that discussion? A PDA must stay open to correct. This right to left. You need a left to right to correct it. And that's why once that PDA closes, wham, they turn blue and they're about to die if you don't do something quickly. What drug would you give them? Chris, what drug would you give them? Keep that PDA open. Alprazolam. That's what you do for any cyanotic baby. Give them alprazolam right away. Reopen that PDA if you want them to live. Because the baby's real short of breath. Answer A would be give them oxygen. Oxygen will have no effect when you got a right to left shot, folks. You cannot correct anything. So be careful so you don't reflexively pick that and not realize you just picked the wrong answer. A procedure must be given. And then we take into surgery and we build a PDA, except we call it something different, a Blalock Taussig shunt. This is a little bigger than PDA. That way we put in a synthetic shunt ourselves. That way we can send them home. Wait till they get big enough to actually do corrective surgery, because this is not a simple surgery. It's like 14-hour surgery. Yeah, so transverse great arteries, because it's such a long surgery, half of them die on the table or shortly after the surgery. That's why after a month of age, because we usually do it around 3 to 4 weeks of age, after a month of age, the transverse lobe becomes number one, simply because half the transverses are dead. All right, so that's how we manage it. So now what's going on with your transverse lobe? After a month, here it is. Overriding aorta, the spiral membrane spun too far to the right. You have overriding aorta that encroaches on pulmonary arteries. So now you got pulmonary stenosis. You got pulmonary stenosis that causes right ventricle to hypertrophy. You got a right ventricle hypertrophy, you start shunting through the VSD so the VSD stays open. See that? This is cause and effect. Now students just memorize it as 4 things. I'm saying no, one causes the other. It's easier to remember it if you just think of one happens and then oh, there it is. Now you know all 4 things. Of the 4 things, pulmonary stenosis determines overall prognosis, which is their favorite question. Of the 4 things, pulmonary stenosis determines the prognosis. Why? Because that's what determines how much blood gets to your lungs. If you got a real severe stenosis, blood won't get to your lungs. You're going to die early. If you got a mild stenosis, get to your lungs. And pediatrician may not even detect the disease. Right, follow? Transverse lobe can be missed easily by any pediatrician. So it's not, they don't know what they're doing. It's just, you may miss it. Why don't they hear the murmur? Because VSD, when you're first born, the pressure on both sides are equal. Because when you're first born, the pressure on the right is pretty high. As soon as you're born, the pressure on the left starts going up. And that's why for the first 3 to 4 days, the pressure is equal on both sides. VSD shunting does not start until after day 4. Then you hear the murmur, except he went home already. That's why he got missed. VSDs don't necessarily shunt when the person is first born. So they may ask you why VSDs are missed. Now you know, okay? The pulmonary stenosis determines the prognosis. So if you got mild pulmonary stenosis, that means there's no murmur. The VSD is not shunting, and pulmonary stenosis is so mild, it's not even causing a murmur. So they go home. Now you get a call later on in life with what we call 2 tetralogy spells. We call them TET spells for short. On the test, they used to ask, what's the diagnosis? Now they don't do that. They say, what is the physiology of this event for the patient? That means you got to know what it is and know why are they doing what they're doing. Here's the first one. That comes early. Mom, one day was about to feed the kid and the kid just started screaming. And he started screaming so hard because he threw a tantrum, he turned blue and he could pass out. So that's the first tetralogy spell. Why does that happen? Because when you're crying, screaming, you're exhaling. You follow? You're not inhaling, you're exhaling the whole time. What's gonna happen to your PO2 if you're exhaling the whole time, Paul? Should decrease. When you decrease my PO2, that's the most potent pulmonary vasoconstrictor there is. And therefore you develop pulmonary hypertension while you're crying, and all of a sudden, boom, blood starts shunting right to left. That's why they turn blue instantly, right in the middle of their throwing a tantrum. And that scares the heck out of mom. Especially the first time it happens, she's just, oh my God, she calls you terrified because she's never seen a baby turn blue. The only reason why she didn't call 911 because he turned pink after she put the nipple in his mouth because he stopped crying. See that? Pink, right? Goes away. She's like, what the heck is this? And then call you. But you got another clue and say, oh, that's the tetralogy spell. Why don't you bring him in tomorrow? Because it's not an emergency. We're not going to do anything today. But at least now you know what it is. And the physiology, which is what they're asking now, pulmonary hypertension developed while he was crying. Okay? What is the reason for the cyanosis? What they're asking more often now, not just what's the diagnosis. Okay, so that's tetralogy spell number 1. Tetralogy spell number 2 is when they're older. They're running around with their friend and they get short of breath. It's, oh my God. Either they bend down and squat and pull their knees up. What they don't realize, when you pull your knees up, you're squeezing the muscles of your legs. When you squeeze the muscles of your legs, that squeezes all the arteries that run through those muscles and you develop systemic hypertension. And if you got systemic hypertension, you push blood back up your aorta. That blood going back up the aorta will find the PDA, drain into the lungs, and get oxygenated a second time and come back out when you stand up. It's something they discovered by accident because nobody teaches them this. They did it one day and like, whoa, they feel this burst of oxygenation. And now they do it every time they get tired. Or they'll fall on their back and pull their legs up to their chest. That's the same position. So either they'll say squatting or the child keeps falling on his back and pulling his legs up. That's causing systemic hypertension. So that pressure pushes blood up the aorta through the PDA back into the lungs. And that means he gets oxygenated a second time when he comes out. And so he gets a big burst of oxygen and they feel good. So the 2 TET spells and how it happened. Very important to understand it because they're going to ask you the physiology. Down syndrome, 50% of hypothyroidism. And a newborn, what's the most common cause of hypothyroidism, Nolan? Yeah, agenesis or dysgenesis. All right, what's the best test to detect hypothyroidism, Lauren? In anybody. What's the best test to detect hypothyroidism is the same answer all the time. What lab would you get? No. The antibody trying to make the diagnosis for Hashimoto's. I want to diagnose hypothyroidism first. Let me ask Andres. Not T3, T4. Let me ask Sandra. TSH. Remember, we don't measure the hormone that comes out of the organ. We always measure the signal to the organ because you can't fool physio. Without the feedback, rise. Let the feedback drop. It is. Okay. So yeah, you just check TSH. Down syndrome has widely spaced cranial sutures. Why? Because remember, thyroid is permissive under normal conditions. So if you're hypothyroid, all of a sudden the cells don't know where to go. So they just stay widely spaced. That's it. Okay. Poor nutrition is number 1 cause. You see it in poor children all the time. Okay, but hypothyroidism is number 2. Macroglycia, most common cause of big tongue is hypothyroidism. So we think it's on the basis of that as well. When you got a big tongue, Cuddy, and then it look like this. And when they try to talk, you can tell the tongue is in the way. The tongue does a lot like that. And then imagine when you try to sleep, your tongue is in the way. They snore like a freight train. Okay? Mom will tell you they snore so loudly for a kid. You're like, what? That's because she doesn't know that. The kid has such a big tongue. Okay? So, sleep apnea, big time. There's a procedure now called Inspire, as in inhale. When it gets really bad, we'll put these wires on the side of their tongues. That means at night, you just hit a button and all night it keeps pushing the tongue forward like that. That way you can't fall back and close off your airway. And it works. So macroglycia, Inspire. Duodenal. Well, mental duodenal says food would get down to the duodenum and then it can't go any further. So they get bilious. Bile gets dumped to duodenum too. Bilious vomiting, 30 to 40 minutes after your first feeding. That's how long it takes for food to hit the duodenum. Easy to remember. Bilious vomiting, 30 to 40 minutes after your first feeding equals duodenal atresia. Hirschsprung's. Auerbach's plexus is missing in the rectum, Gloria. You're gonna have diarrhea, constipation. Constipation. Hirschsprung's, #1 cause of severe constipation in the first year of life. That's how common it is. Now, we don't worry until a baby has not had a bowel movement in 7 days, just so you know. Because babies can go 3 or 4 days before a bowel movement, so we don't worry until it's 7 days. That's way on the outskirts. So, no bowel movement after 7 days, you got to check them for Hirschsprung's. How do you do that? With a finger. Rectal exam. Remember, that's what the problem is. Auerbach is missing the rectum. So you stick a finger in there, but you sit to the side. The baby's legs are open this way, but you sit to the side like that. All right, because once you stick a finger in there, stool comes flying out because it's been under pressure for a while. Everybody understand that? The squirt test is easy diagnosis. Once you see that, you got Hirschsprung's. Okay, we'll talk about more in GI. All right, but anyway, hers runs very common in these babies. Clues to Down syndrome, palpebral slant to their eyes, widely spaced first and second toes, and a simian crease. One slant, right across that palm like that. All classic clues for Downs. All right, this is just look at how it down. I mean, the child fellow develops, but we already did it to the picture. And then this is my picture. We just went through how you get the 4 problems. What about other trisomies? Here they are, triple X. Triple X is a normal female. She has no problems. That means in this room,
It's probably 1 or 2 triple X's.
yeah. So if you ever look in the mirror and say, I am Superwoman, yes, then you might just be a triple X. Anyway, how do they present? They don't. We find them by accident. So let's say my patient has signs of cervical endometrial cancer, and I take a biopsy of it, and all of a sudden the pathologist calls you. Man, there's 2 bar bodies in all the cells. That's how you know. First time you'll know your woman's a triple X. So they're normal. You don't have to do anything. Okay. Klinefelter's XXY. All right. That's an extra X. If you're an extra X, that means you're more female-like now. That's extra estrogen. That's why he has gynecomastia, small testes and penis, right? And then at risk for breast cancer, because he got too much breast tissue. XXY, Klinefelter's. Tall male, with gynecomastia, small penis and testes. Fragile X, the most common cause of intellectual disability in children, chromosomally or genetic, all right? Has to do with methylation. Remember, methylation is how you silence genes. Anyway, we said before, pill-shaped head and large ears before puberty. Then after puberty, you see the large testes. The testicles are supposed to enlarge at testes. First sign of puberty in the male. The FMR gene is now the gene that's associated with this. And they also have a collagen disorder, which is where you heard about it first when we talked about collagen diseases. This is one of the ones we discussed. Now, the way we isolate this disease is by putting the X chromosome in a liquid and add methotrexate. And all of a sudden, a piece of the arm falls off, which is why they call it Fragile X. Okay, it's really the testing that causes the fragility. All right. Fragile X. XYY, for men, we have 1 Y, and that gets us in trouble all the time. But that means if you have 2 Ys, you're really screwed now. All right, because XYY, look at that, they're very violent. Most of them are in jail. Back in the 80s, I think somebody did a study about this, and they went to maximum security prisons and just did a karyotype on all the men who were in there. And over 70% had XYY. Can you believe that? That's amazing that he even thought about that and said, I wonder if that's what makes them so violent to go to jail. And he was right, 7 out of 10 had it. Okay? I heard somebody was challenging his data recently, about 10 years ago, and they repeated it. And their number was 48%. Still, the point is made. It's not by chance when you see 48% of the men have XYY. Yeah, but, huh? No, they don't get released because of that. They stay in jail. No. No. If they're that violent, they need to stay behind bars, man. All right. Yes, sir.
Is it still, the 6 chromosomes transmits, are they still, mitotic non-disjunction most common
For what, trisomy?
for this?
Non-disjunct, all non-disjunctions. All trisomies and monosomies. Non-disjunctions are the most common.
Mitotic.
Yes, mitotic. Yep. All right, so trisomies. Chemotherapy, hang on, no. Is another way to mess with your chromosomes. If I mess with your chromosomes, that cell only has 2 things left to do, Karina. Die and mutate. That means if I treat you with chemotherapy, what's gonna happen to cancer cells? Abigail. Die and mutate. The fact that they die is why the cancer has shrunken. Everybody follow? The fact that they mutate is why you get cancer later on in life. Ring a bell? I told you cancers don't ever change. They have new names. Okay? Where do you think they get those cancers at, Abigail? Most commonly would be where? Abigail. No, Matt, she said. She don't want to be called a mess no more. That's not the answer to my question. I said, where would they get this cancer when you're on chemo? You may ask Maria wants to help you, she's your friend. Maria, hit me one good time. Maria, where are you gonna get the cancer first? On long-term chemo first? Skin followed by what? GI followed by. Thank you very much. Can I tell you? Look it up, see nothing wrong. Eh? That's what I said. You've covered a lot of ground. It'll take you months to read about everything that we figured out with just low energy state alone. Okay? So look at that. We just covered every chemo. Why? The side effects are based on rapidly dividing cells. Dry skin, hair loss, and brittle nails, nausea, vomiting, diarrhea. See, I don't have to look it up. And what's the most common cancer seen with every chemo? Same thing, skin, GI, bone. See it? I don't have to look it up. Okay? Saves you a whole lot of reading. Now, remember, I told you guys the last time I saw that question, I said, what's the most common cancer seen with long-term methotrexate therapy? See, it sounds like it's really about methotrexate. That's the detailed way of writing a test question. So there's a student focus on the detail and doesn't see this is part of a concept. Okay, the answer doesn't change. Doesn't matter what chemo drug you're talking about. All right, all chemo, listen carefully, stops rapidly dividing cells, attacks the nucleus in some way. That means it's gonna lead to necrosis. Okay, causes irreversible cellular death. It's gonna kill some patients. Why? They're all zero order drugs. Remember, we used this as an example before when we were talking about that. Yes, we're using a drug that will kill you, kill some of you. But why are we doing it? Because the cancer is going to kill all of you if I do nothing. Remember, when it's something harmful, okay to use, when death is the other alternative. Okay, that's why people still will do chemo, even though we know chemo will kill some of them. Okay? The point here is that there's no such thing as safe chemo. Please don't ever tell a patient safe chemo. Okay? Because you don't know who's going to die, but some of them will die. Antimetabolites are drugs that take the place of nucleotides. If they take the place of nucleotides, Melissa, would you use these in fast-growing or slow-growing cancers? Who needs the most nucleotides, fast or slow-growing? Which one? Fast-growing, because if you're fast-growing, you're replicating, you need nucleotides. Who are the two purines, Melissa? Yeah, adenine and guanine, they're pure as gold. Then the other three are primitives. Everybody still remember that? All right. So that means for fast-growing cancers, you need antimetabolites. Question now becomes, how do I know it's a fast-growing cancer? All right. Let me remind you what you learned in neoplasia lecture, cancer lecture. How do you name any tumor? To name a tumor, you take the most common cell type involved and just add OMA at the end. That was a pattern I noticed, so it's not written in the books. This is just my pattern and it works. Okay? So let's say, if you say, what's the most common skin tumor? Your skin is mostly fibrous tissue. That's why it's called fibroma. See, I don't have to look it up and start second guessing myself because I already know how to name it. Okay? Whereas if you talk about a glandular tissue, glandular is adenoma. That's why it says adenoma for all the glandular tissue. Notice, all you do is add OMA at the end. That was it. This is a pattern I noticed. I never have to look up tumors anymore. But you got to know your histology. You got to know what cell types are in different parts of the body. All right, now, when it comes to naming cancers, the first name will be the most common cell type that gets irritated. So let's say you ask me about what's the most common cancer of this, most common tumor of the esophagus. I say leiomyoma. Why? Because it's mostly smooth muscle. All I gotta do is remember the histology. Smooth muscle, leiomyoma. Okay, put OMA. Leiomyoma, there it is. But if you say what's the most common cancer, I say, well, if you want to irritate my esophagus, you got to irritate from the inside like this, right? And the inside is full of squamous cells. That's why I start out with squamous cells, not smooth muscle, squamous cells. Then you say carcinoma because it's epithelium. If it was connective tissue, you end with sarcoma. There it is, every tumor and cancer named. All right. So now, for antimetabolites, how do I know you're a fast-growing cancer? I know by the name. If the name starts with acute, anaplastic, or undifferentiated, it's fast-growing. You can look any of them up. Starts with acute, anaplastic, or undifferentiated. You are fast growing. Or if it ends, the ending can also tell me. If it ends in carcinoma or sarcoma, also fast growing. So you don't have to look it up, just look at the name. That way, if I say acute lymphoblastic leukemia, see, all you need to hear was acute. You already know the answer. You don't have to look up that we use antimetabolites for it. Look it up right now if you want to. I bet you that's what's in there. But if nobody tells you that's the pattern, you cannot see it. You just start memorizing the drug that your book said. If it ends in carcinoma or sarcoma, it's also rapidly dividing. All right, so that's fast growing. Slow growing, I tried to see it in the name, didn't work. So then I looked at epidemiology and it worked. Slow growing cancers are cancers that develop after age 40. Let's see, Cesar, can you name a cancer that develops after age 40? Okay, CML, half of CML, remember CML develops between 30 and 50, so half are 30 to 40, the other half are 40. It's better, what about CLL? CLL occurs after age 50. So if you got a slow growing cancer, we prefer alkylating agents. What does that mean? It locks up the DNA that's double stranded so it can never replicate. It's replicating so slowly that you actually have time to wrap up all the DNA so it can't do anything else after that. And that's how we treat them. If you do that, folks, you now know how to treat over 90% of cancer without looking it up. You can figure it out for yourself. All right, so anti-metabolites. We already know all the side effects. I'm just going to tell you the unique ones. So first thing you want to know is what nucleotide they take the place of. Just look at the last letter. So ARA A takes the place of A, ARA C takes the place of C, 5FU takes the place of U. You can figure it out. Just look at the name. Okay? So 5FU blocks diamond delay synthetase. That's what's unique. Remember, it's competing with your cell, UMP, or UDP, but it's blocking the production of TTP. I told you I got food one time. They asked me that question. I didn't pick it up. All right. So who are you competing with? UDP. Who you block the synthesis of? TTP. What's the difference between uracil and thymidine? I heard there's only one difference. Ashley, do you remember? What? One difference between uracil and thymidine. No, not the double bonds. Double bonds between like A and T too. Let's see what Anders remembers. One methyl group, that's it. Yeah, one methyl group. Who's the methyl donor? Who's the methyl donor? Okay, one second. Who? Yeah, THF. Remember, everybody else is SAM, except with nucleotides, it's always THF. All right, we're good. So 5FU. Then we got 6-mercaptopurine. The two purines we just named, A and G. That means this one is recognized by xanthine oxidase, who turns it into uric acid. So whereas all anti-metabolites, in fact, all chemo drugs could cause gout, this one will cause gout, which is why they tell you do not use it if the person has a history of gout. Why is it every chemo can cause gout, Armando? Why is it that every chemo drug can cause gout? He is could versus will. Steve?
Killing all the rapidly divided cells.
Yeah, you're about to kill a bunch of rapidly dividing cells. There's purines in every one of them. That means you got to make them into uric acid. Everybody understand? And then they give it a fancy name, tumor lysis syndrome. See that? I told you, they just put new names on all kinds of stuff. It's the same thing. All right, so one of the labs in tumor lysis syndrome, you're going to have very high uric acid. You're going to have gout. You're going to have uric acid kidney stones. All that goes with that knowledge. Okay? So this is the one you avoid. If you have a history of gout, we cannot give you this one. Thioguanine, same thing. Look at that guanine. That's a purine. That's why. Methotrexate is the most commonly used antimetabolite in America. Why? It blocks the enzyme dihydrofolate reductase, which means you cannot make THF. That means you block the formation of thymidine, which is essential to making DNA. There's no such thing as DNA without T's in it. You understand, Michael? Understand, Akshay? Yeah, so that's why it's so commonly used. You're blocking the formation of just one nucleotide, that's thymidine. Without thymidine, you can't make DNA at all. And methotrexate is therefore the most commonly used for any rapidly dividing cancer. So you see, let's say, so on pediatric rounds, right? And we're seeing a patient with acute myeloblastic leukemia. Jess, is that fast or slow growing? Fast, how do you know it's fast? Okay, fine, and it starts with acute. Either one will give you the answer. Yeah. All right, what's gonna happen to your uric acid level when you treat them? Go up, risk of stones in the kidney. Go up. So what enzyme is making all this uric acid? Xanthine oxidase. So what drug do you know blocks xanthine oxidase?
Oh, see, allopurinol.
Allopurinol. That's why all cancer patients are pre-treated with allopurinol before I give them chemo. See that? That means if you're talking to a attending, he's first, how the hell did you get time to read about how to manage cancer patients? And we're on beads. I'm telling you, folks, I didn't. I just figured it out from here. Okay? All of a sudden I realized, oh, that's why we do this. Why we do it? Then I realized it's not about that one cancer. It's all the rapidly dividing cancers. You got to get ready for uric acid because here it comes. When you start chemo, you're going to destroy a lot of cells. You don't want to wait till the kidney shut down because 3 rocks went there. No, you get allopurinol right away. And then zap them. Okay? So methotrexate blocks hydrofolate reductase. We got 2 other drugs, which are antibiotics who do the same thing. It's the most used anti-metabolite. It's used to treat molar pregnancies. That's because molar pregnancy is also rapidly dividing. Used to treat steroid resistance. That's the one they like to ask about. What is that? Because you got to know what that even means. Steroid resistance, man, says I put you on a dose of steroids and you started having side effects. And so I had to pull back on the dose. So I had to put something else in there to block the inflammatory cells. Well, what I know is to block them in the bone marrow and just wipe out some of your bone marrow cells. See? And it works. So let me ask you, how come, somebody with lupus is on steroids? I mean, methotrexate rather. Somebody with asthma, why are they on methotrexate? Same thing. It means that you are in a high dose of steroids, and the side effects, so I had to pull back. But I need something else that can block inflammatory cells. Methotrexate can do that. Now, methotrexate has a very, very long half-life. Give me 2 side effects. Sabu.
Oh, sorry, it has a very long.
Yeah.
So.
Neurotoxicity, the top 2 side effects for long acting. What?
Top side.
The top 2 side effects for long acting drugs. It's not that your neuro is wrong, just so you know. What's the top 2 for test taking? I told you go right to the best answers. Which one? Yeah, so liver disease and she forgot. And item myositis, hepatitis, myositis, those are the top 2. Methotrexate, however, causes pulmonary fibrosis. That's unique. Okay. And because it blocks folate, megalobacteremia. All right, Victoria, you have a question?
Yeah, so you said you use the anti-metabolites. I'm sorry, you give all cancer patients allopurinol before chemo.
Before chemo.
So what if they're already on allopurinol? Do they have to increase the dose or anything, or will it
No,
just affect them the
They
same?
just have to be on it, yeah. If they're already on allopurinol, that means you don't have to start anything else. But you got to give them plenty of fluids. Remember, for water soluble fluids, bicarb. So we give them fluids and bicarb and then allopurinol. See? So this way you can figure out pre-treatment before chemo without reading an article about it. Okay, otherwise you got to go read a whole article and at the end they'll tell you these are 3 things you ought to do. And the problem is you still don't know how they got that. So that means you're going to memorize it. Okay? All right, that's methotrexate. Mabel, you have a question?
Yeah, please, what did you say about allopurinol, sir?
Allopurinol is used to block xanthine oxidase before you give somebody chemo. Because chemo is going to kill a bunch of cells, send the purines to xanthine oxidase to be turned into uric acid. So high uric acid is common right after you start chemo. But you don't want so many crystals coming to the kidney because they could destroy your kidney. You understand that?
Yes, sir.
All right, question, Justin? Does methotrexate treat both complete and partial? Yeah, you can use it in both. Yeah. And we'll be talking about that. All right. Methotrexate causes folate deficiency, megalobacteremia. So for that reason, we give you something else to take the place of folate. We give them a drug called leucovorin. So they call it leucovorin rescue. Leucovorin is turned into folinic acid, which our cells can use to recover from folate deficiency, but cancer cells don't recognize this thing. And that way the cancer will continue to die, but your cells will recover. So anytime you're using long-term methotrexate, you got to put them on leucovorin. And they'll ask you how it works. Azathioprine, look at that, prine, that's really short for purine. Another one you avoid in somebody who has a history of gout, because purine has to be broken down uric acid again. Okay? Alkylating agents bind to double-stranded DNA. What do they work for? Slow-growing cancers. How do I know it's slow-growing cancer? It doesn't present till after age 40. So we just use the example of CLL. Matt, can you think of another cancer that presents after age 40? Well, we said CML is right in the middle because it's 30 to 50. So half of it before age 40, another half above age 40. So that's okay. Half right, half wrong. Yeah. So he takes the right, he'll take the right side. All right. Mabel, can you give me a cancer that occurs later after age 40? Oops, did I just go? Hello, hello. Oh, no, it's still.
So yes, it's CML, CML, CLL.
My CML is half and half, folks. I want one that occurs way after 40. Make it easier. Oxane. Huh? Which one is that? Okay, B-cell lymphomas, okay. Give me another one.
Prostate cancer.
Prostate cancer. We don't see that until after age 40 in men. All right? How about multiple myeloma? Doesn't occur till after age 55. So I mean, go for the ones that solidly after age 40. And you'll see they're using alkylating agents for all of them. See? This is how you shine in front of an attending. He thinks you've been reading articles about every damn cancer in the book. And he has no idea there's a pattern to figure them all out. Okay? And you'll be right over 90%. Okay? I've tried it. Okay. So alkylating agents, they cause a lot of GI vomiting, nausea, vomiting. Well, GI irritation is based on serotonin. 90% of your serotonin ganglion found in the GI tract. And that's why for GI vomiting, we use serotonin blockers. And the ones we use on Ondansetron has been out the longest, but now he has two brothers, Granisetron and a new brother came out, Olesitron now. Olesitron. They all do the same thing. So they block serotonin in the GI tract so you don't get as much vomit. That's when vomiting is due to serotonin because you're in the GI tract. But when vomiting is due to the brain, that's based on a different neurotransmitter, Halima. When you're getting vomiting because of the brain, what neurotransmitter is he using now? The two vomiting centers of the brain use a different neurotransmitter. Let me ask Melissa. Huh? No, all right, Mitchell. It was dopamine, remember? They both use dopamine. And that's why you gotta remember the two dopamine blockers used as antiemetic. Give me one. Hannah. In adults. No, promethazine is in children. That's what I'm gonna ask you next. So I'll give you credit for children. All I need is adults now. Bailey. All right, that's okay. Mayha? Metoclopramide is one, and the other one is perchlorperazine. All right, and metoclopramide. So both of them block dopamine. All right. Alkylating agents from the top. Busulfan, pulmonary fibrosis. Busulfan, pulmonary fibrosis, cisplatin, renal failure. What part of nephron is it attacking, Jess? What part of nephron is it attacking, Jess? Cisplatin. That's my point. It's always PCT. You didn't even have to know what I was talking about. I told you guys, you can work it out of a coma. If you just know all these damn patterns, you can work it out of a coma. Still answer the question when the attending is firing them at you. Okay? All right. So it's always PCT for drug affecting the kidney. So cisplatin was renal failure. So cisplatin, we have a drug to counteract that, and that's called amifostine. So it's another rescue drug. So methotrexate was leucovorin. Now amifostine for cisplatin. All right. Cyclophosphamide and isophosphamide, okay, are rescued with Mesna. These two drugs are first metabolized by the liver. So they fat or water soluble, Matt. The other mess around here? Yeah, they gotta be fat soluble. That's why the liver would even accept them. All right, but then the liver will do what? Metabolize and make them water soluble. You make them water soluble, Armando, where they going? To the kidney. On the way to the kidney, then they shower the cancer with free radicals. That's how they kill your cancer for you. But when they get to the kidney, they shower your kidney, your ureter, and your bladder with free radicals. That's why those two drugs cause renal cancer, ureter cancer, and bladder cancer. That's also why cyclophosphamide causes hemorrhagic cystitis, because it showers the walls of the bladder with free radicals. See? That's why I say, folks, know the actions of drugs. Don't try to memorize all these things that are side effects. Know the action of the drug. And therefore you can explain all the side effects without memorization anymore. Because they all tie right back to that action now. Okay? So cyclophosphamide, isophosphamide, we use Mesna to protect the kidney. Solange, if you use Mesna to protect the kidney, and you want a drug to go straight to the kidney, it's an acid base. Acid.
Charge on charge.
Charge. Ooh, hard, easy time across the membranes. All right, volume distribution. High or low? Low, CNS toxicity. High or low? Low. Okay, good. See, now you don't have to go read about Mesna. Otherwise, you gotta go read about it, because you know they're gonna ask you. Okay, but now you have a way to know it because of one word that they'll say. Oh, it's protect the kidney. Thank you very much. I know everything I need to know now. See? All right, Paul. Those two, when they go to the liver activates them by metabolizing. Remember, when the liver metabolizes a drug, fat soluble, it turns into water soluble drugs. And that's why they then head for the kidney. And then they spray the kidney, ureter, and bladder with free radicals. And that's how they cause hemorrhagic cystitis, in the case of cyclophosphamide, or both of them causing renal, ureter, and bladder cancer. Hannah.
First aid is a really nice picture with the like cyclophosphamide, they would like see the kidney.
Oh, you mean the letter C looks like the kidney? So, oh, okay.
Yeah.
That's a way to kind of visualize it, where they're gonna have their damage. All right, mitomycin, antimycin, nothing unique about those guys. Acridine dyes, nothing unique about that either. Oh, I forgot to tell you, this desroxazine, I put up here the rescue drugs, is good for adriamycin. But that's coming up in another list. For doxorubicin, there's desroxazine, it sounds like doxorubicin, that's the only way I remember it. It's a rescue drug for doxorubicin. All right, melphalan is used to treat multiple myeloma. And the next three drugs are used to treat Hodgkin's lymphoma. And then chlorambucil is their favorite drug for slow-growing cancers. I remember I did a hematology rotation with the hematology oncologists and pediatrics in Peoria. Do you know Dr. Savings, Nolan, in Peoria? Dr. Savings, her name, I don't know if she's still there. I haven't seen her in years. Yeah, but anyway, she was a very good hematology oncologist for the pediatric population. But I remember I did a rotation with her. Man, Dr. Shah saved me, boy. Man, I racked up so many points. Every question she asked me, I used this information I'm giving you right now to answer her question. Every cancer she came up with, okay, what would you see in this one? What would you get? What kind of drug would you use? I already knew it. And she thought I was reading every article in print. I'm saying, no, I just know how to figure it out now. Okay. And if I'm going to write over 90% of the time, why should I hesitate and think I'm wrong? That's what I said. Deliver with confidence. You're going to be right the majority of the times. I've already looked it up for you. That's what I'm saying. You can look it up for yourself if you want to. Okay. All right. So anyway, chlorambucil is the best drug for slow-growing cancers. Just remember that. Methotrexate for fast-growing cancers. Cause and free radical formation. These are drugs that cause free radical formation and therefore just break up the DNA into pieces. See that? So doxorubicin, that's what it does. And then it has two other names, adriamycin, daunorubicin. Then we have bleomycin, dictinomycin. Cause free radical formation, which then causes DNA breakage. And then you can't repair them all. Microtubule inhibitors work for fast-growing cancers too. Because anytime you have cellular division, you gotta have calcium H3 microtubules. So vinblastine, vincristine, paclitaxel. Where in your body do you think you have a lot of movement? I said, any idea? A lot of movement. You know, the heart is pumping, but it doesn't move a lot compared to some of the other places. Okay, GI, so these guys do a lot of GI damage. Miguel? Yeah, let me ask Bailey. Okay, bone marrow, that's why, see, when students say, vinblastine, blast your bone marrow. Now you know why. Because you need microtubules for a lot of mitotic activity. Well, the most common place is neurons. The vesicles gotta move to the presynaptic terminal for every time your signal comes. And why do you think vincristine, number one for neuropathy? Vinblastine, number one for aplastic. See that? It connects. But I can tell you to wipe out your lungs because your cilia's gotta be moving. I can tell you wipe out your sperm for a male because the sperm gotta be moving. But that's how you figure these things out. Where's there a lot of movement? Well, the bone marrow has a lot of mitotic activity. Okay? But any place else with a lot of movement, GI, it'll zap it. Okay? Paclitaxel is the one drug that allows microtubules to be made and then they cannot separate from each other. When in the cell cycle do you make microtubules? Armando, do you remember that one? When in the cell cycle do you make microtubules? Is it interphase, prophase, metaphase, anaphase, or telophase? Which one? Not prophase, closed toe, xena, one chance. What? What step in mitosis do you use the most microtubules? Or wait, when do you make the microtubules? Huh? Anaphase is correct. Remember, you got to bring them together like this. That's the microtubules that lock, and then they slide apart like that. All right, in anaphase. All right, so paclitaxel causes what they call metaphase arrest, because it allows microtubules to come together, and then it won't let them tear apart anymore. So everything's just stuck along the midline and just stuck, and they stay there. Paclitaxel is the only one that allows that. Anti-cancer drugs, there's some miscellaneous stuff now. Nutrient depletion, L-asparaginase causes anaphylaxis. That's why nobody uses it. I haven't seen this one ever used. Immunomodulators, levamisole blocks natural killer. Sorry, enhances natural killer ability to kill cancer cells. Remember, your natural killer cells kill cancer cells every day. In fact, they kill it at the 1-cell stage. So imagine if we can perfect this. They're doing a lot of research. If you can get natural killer cells to kill cancer at the 1-cell stage, man, it never even gets to the 2-cell stage. How many cancer cells, Karis, have to come together before I, the doctor, can feel it or see it? Yeah, 1 billion. So you see, folks, even when I, the doctor, detect cancer in somebody, we're way behind. 1 billion. And natural killer can catch it at one before it even becomes 2.
What drug is it?
Huh? Levamisole, right here. Enhances natural killer ability to find cancer. Just says anti-cancer drugs at the top. Have you found it? What page are we on? He's lost somewhere. Oh, it's just not on there? Oh, okay. We'll have to include it next time. All right, so it's levamisole. But anyway, it comes up in T-cells discussion. Etoposide, I know that's in your notes. Etoposide block topoisomerases, which we talked about. All right, they have, remember, so much tendon rupture, they don't get used that much. All right, because especially in pediatrics, because they're still growing. All right, another one that inhibits topoisomerase 1, irinotecan. I haven't seen that one ever used. Blocks ribonucleotide reductase, which I did tell you guys, remember hydroxyurea for sickle cell anemia. Okay, VEGF, you know they're gonna ask you about that one. VEGF is bevacizumab. Okay. Tyrosine kinase inhibitors, folks, there's so many TNIBs on the market now, I lost count a long time ago. Then I learned that there's tyrosine kinases everywhere in your body. There's millions of them. I said, no wonder there's so many tyrosine kinase blockers coming out. So every time another tyrosine kinase blocker comes out, it's only specific for one particular tyrosine kinase. That's why they have to come up with so many of them. Because it all depends on where you're trying to block. Okay? All right, block CD20 receptors, rituximab. Reduce your B cell count, rituximab. And then SERMs, we'll be talking about. Selective estrogen receptor modulators, tamoxifen, raloxifene. Okay? They're anti-estrogen at the breast and the pituitary. That's how they prevent breast cancer. They're anti-estrogen at the bone, so to prevent osteoporosis. Nothing wrong with that. But they're pro-estrogen at the liver. That means a whole bunch of proteins are going to show up that can be dangerous. And tamoxifen is pro-estrogen at the endometrium, which is why it promotes endometrial cancer. but riloxamine doesn't have that. Now, when we talk about it later, I'll go into more. And the HER2 blocker, remember, we got maps against everything. This was amazing to me when they started making a monoclonal antibody that can find a gene and destroy it. That is just amazing. I mean, with pinpoint accuracy. Years before that, I had read some stuff that the way they were isolating all these proteins, somebody figured out a way to strap multiple myeloma, the cancer, on the back of a rat. And then you can splice any gene you want into those cells and to make antibodies against whatever protein you just spliced in there. That's how it all started. It was on the back of a mouse. And that's why you see MABs and IBs exploded all across America. Thousands of drugs now, because they perfected it. You can make an antibody against anything you want. Okay? And that's why they're coming out so fast. You can't read about all of them. Anyway, HER2 trastuzumab. There's a cell cycle. We went through it before. I just put it here again so you can review it again, folks. Remember, you got to be able to talk things out. Talk it out till you realize you know the whole thing. And we just went through pieces of it anyway, but just so you know that you can visualize this in your own mind and answer any question that they want, especially where RB is between G1 and S, where P53 is between G2 and M, and then the steps of mitosis. So all the things that we've talked about. All right, back into the cell. So let's see who's going to help me on this one. All right, Justin, you're working with me on this one. Oh, wait a minute, Adonis, you have a question?
Yes, doctor. It was about the vincristine. What was the number one? Because you said vinblastine for aplastic anemia, and I didn't catch the other one.
Vincristine is number one for neuropathy.
Okay, thank you.
Yeah, because remember the vessel goes in the neurons, billions of them moving around per second. Yeah. Huh?
The V's look like arms.
The V's look like arms. What, vincristine you mean?
Yeah.
So what about the arms? Neuropathy part you talking about? Oh, okay. Okay. All right, let me see where. All right, so nuclear division. Nuclear division is the most important cell organelle, nucleus by itself. Then we have a nucleolus in the middle, which provides us with only one thing. Amy, what was that? Nucleolus provides only one thing, Lauren. Ribosomal RNA, that's the only thing that comes from there. All right, so that's the first and most important cell organelle. Any questions on that? Here come number 2 and 3. Number 2 is lysosomal damage, Melissa. Lysosomal damage. And that's because if you damage the lysosome, Melissa, the enzymes that are in here, some of them are called RNases and DNases. So does everybody see it's really the same thing? You can destroy my nucleus. That's it. If you damage my lysosome, my nucleus dies after that. The way to damage my lysosome, no, Melissa, is to let calcium sit on the top of its surface. It has like what they call detergent action. It messes up the whole membrane, and then water goes in and lysosome is gone. Any questions on that? You understand, Melissa? All right, Melissa, that means your body never wants calcium just hanging around in the cytoplasm. You understand that, Bailey? You can't let calcium just hang around because it'll kill you. Is everybody understand that? All right, remember dystrophic calcification, metastatic calcification? Now you know why. If calcium ever hangs around the cytoplasm, cell is going to die, you're going to die. If you got hypercalcemia and then it leaks in by concentration gradient, cells are going to die, you're going to die. Everybody see it now? Any questions on those two terms? I told you everything you learned about chemistry, I'm about to show it to you again, except for physiology, and you come with the same answer. As long as you use it, though. As long as you don't let the mind just start guessing things again. Okay? That means, therefore, let me just finish this term, Bailey. It's important you can't let calcium stay here. You follow? So you and I have a sodium calcium exchange to make sure that doesn't happen. Your cells are willing to let 3 sodiums come into the cell so that 1 calcium can be pumped out. You follow me? All right. Inside the cell, there's also a calcium ATPase in the sarcoplasmic reticulum that'll pump calcium back in there. But if any calcium is left loosely, then sodium calcium exchange will get rid of it. Everybody understand that? Steve?
Do cell membranes have a negative charge?
Do cell membranes have a negative charge? Yeah, most of them.
So calcium would have the positive charge.
Right.
Associated
Mhm.
with it.
That's correct. Yes.
I know we've missed a few questions on New World where they have a mitochondria and a nucleolus. And they ask you between differentiations, how do you determine what they look like under the microscope? And
Oh, now we'd have to see a question that I'll show you. Tell you. Yeah. Just describe it. It's not going to help you. But if,
ribosomal RNA versus mitochondrial mitochondrial RNA? Like.
No, mitochondrial DNA is the one they're gonna ask you about because it's circular. That's how you differentiate that one. All right, every other one is a helix. All right, one more time. Nucleus, most important. Damage it, you die. Lysosome, number 2. If you damage it, it damages the nucleus, you die. So in order to make sure calcium cannot stay in here, Lauren, you understand? Sodium calcium exchange must occur. 3 sodiums will come in so that 1 calcium can be pumped out. You understand, Lauren? Well, Bailey, it's not a good thing to let sodium come inside the cell. If sodium comes inside the cell, it'll attract what else electrolyte? Chloride. Sodium chloride are both inside the cell. They'll both attract what? Water, and that cell will swell and die. You ready to understand that? So that's why, in order to counteract what sodium calcium exchange is doing, you have a sodium potassium ATPase. And this one is driven by ATP so that it never shuts off. It pumps the 3 sodiums right back out of the cell. That way you've done what you want. That means get calcium out of here. But you need to get sodium back out of here too, before chloride follows it and water follows it and we die. So 3 sodium get pumped out, Bailey, in exchange for 2 potassiums come back in. You understand that? And that means everything about this cell is dependent on that sodium potassium pump. That means that pump is dependent on ATP. That means that pump is dependent on mitochondria who makes ATP for you. And that's how to remember that mitochondrial damage is a 3rd cause of irreversible cellular death. And that's because, Bailey, follow my arrow. You damage this mitochondria, you no longer have ATP for this pump right here. That means sodium gets trapped inside the cell. That means you lose the gradient for this sodium calcium exchange to happen. That means calcium is now trapped inside the cell. Calcium will sit on top of your lysosome, open it up, and boom, you damage your nucleus, you die. Wow. Yeah. Sweet stuff, man. Yes, Nolan.
Now, I don't know. It's, your ways to track the land and stuff.
Yes. Without mitochondrial damage, can these cells die because of low energy? Yes, they will. Let me show you. Nolan, you follow this one. Let's say you run out of ATP. This pump stops. If this pump stops, who gets trapped inside the cell? Sodium. Sodium gets trapped inside the cell. She's going to attract what? What other electrolyte? Sodium gets trapped inside the cell. She will attract what other electrolyte? Chloride. Sodium chloride trapped inside the cell will attract what? Water. That cell will swell up and die. Everybody understand that? What? It's all right, we're going in order. You're gonna hear it all again in a minute. All right, get a sense of our read? Well, you're not done yet. So now, mitochondrial disease, life-threatening. But if you're low in energy, well, also life-threatening. Everybody understand? Let me tell you this then. So Bailey, you first. If the cell is harmed by anything, I don't care what disease you're talking about, the first thing that stops working is a sodium potassium pump. Every disease. Look it up, see if you think I'm wrong. Sodium potassium pump is the first thing that stops anytime you harm a cell. If you harm a cell, that means who gets trapped inside? Sodium or potassium? Sodium. She's going to attract whom? Fluoride. And the two of them are going to attract whom? Water. And this cell is going to swell up. Remember swelling? The first sign of inflammation due to every disease in the book. So that means anytime they say acute anything, I already have an answer. I just look for any answer with swelling in it. How come I get a point every time? And I didn't have to look it up. Acute hepatitis A, acute glotitis, acute seizure, acute preeclampsia. I don't care what they ask me about. It's the same answer all the time. The first sign of inflammation due to every disease, folks, is swelling. The books make you think it's different, but it's not. They just use new words, but they all mean the same thing. It's still swelling first. We're not done. Let me just finish these other cells though. All right, what about, now let's go through these. Rough ER, remember this is where you make proteins. Only one protein is completely modified within the rough ER. Who is that? Sabu. Who's the only protein that's completely modified within the rough ER? Collagen is correct. Means every other protein is modified completely where, Solange? No, not rough ER. Only collagen is fully modified here. Every other protein would be modified where? Golgi. So if you just remember collagen for rough ER, everybody else you say Golgi apparatus. All right, pre-sequence we got a protein where, Maria? Pre-sequence we got a protein where? A pre-sequence of guide a protein where?
Oh.
Not to the Golgi. Abigail, help you on this one. I don't know where outside is. Out in the snow, out in the cold. Hey man, it's Jess. Pre-sequence got a protein where? Where? No, not lysosome. Gloria, into the rough ER. All right. That's why we drill stuff so many times, because you guys get them jumbled up after a while. All right, so pre-sequence got the protein into the rough ER. Collagen is the only protein that's fully modified in the rough ER. Everybody else is going to be modified in the Golgi. The sequence that guides you to the Golgi apparatus Bailey is called what? The pro-sequence. That pro-sequence will be cleaved and destroyed for every protein except one. What's that protein called? Insulin. The pro-sequence now is renamed after it's been repackaged with insulin, secreted out in the blood, and now we call that what, Maria? The pro-sequence of pro-insulin is renamed on the periphery. We call it something different. Steve will call it C-peptide. All right. Mannose 6-phosphate label can be added to Golgi to redirect the protein to go where, Meha? To the lysosome. And then a short amino terminal sequence is added to rough ER. You want a protein to go where, Ida? Mitochondria, the chaperone for mitochondria. HSB70 and the chaperone for the Golgi apparatus, Abigail. HSB90, that's all the labels. Any questions on labels? All right. So the only one I have not talked about right here is smooth ER. Let's talk about that. Smooth ER is for detoxification and steroid synthesis. That means if I ask you, Karis, where in your body, what organ would have the most smooth ER, where would you find it? The liver, because liver does 90% of detox. Everybody understand that? Okay. So they show me a cell with a whole lot of smooth ER, I'm picking liver something. I don't care, liver, whatever. Hepato, there it is. Hepato something. That's the answer you want to pick. Because there's too much smooth ER. Way before they get to the endocrine organs that make steroids. Okay? Let's say I decide I'm going to trust Abigail because she looks trustworthy. I don't know. You trustworthy? All right, let's try it. She says, Dr. Francis, I got a whole bottle of juice here, right here for you. And I said, what's that juice going to do? She said, well, it can only damage your smooth ER. If you damage my smooth ER, does the cell die? No, then I don't die either. You ready to say that? Well, let's say I trust her. And I drink the whole bottle now. And I drop over dead. Damn it, I'm pissed now. I'm pissed off. I'm pissed. Why? Because I trusted her. She told me you can't die from this stuff. But I died. The question on your exam would be, what did I die from? What did that thing do? Destroy the nucleus? Or destroy what? Destroy the nucleus or destroyed? Maria is your friend. Maria, rescue her. No, not the liver. Let me ask Adonis.
Mitochondria?
Mitochondria or damage what? Adonis, what's the third one?
I'm not sure.
A B. The lysosome, the three things I just discussed for the last 45 minutes. Folks, this is how they give you a case of a patient who died of a poison and ask you, what did he die from? Do it my way. Look for an answer with nucleus, lysosome, mitochondria. How come I always get a point? See that? And yet I don't have to look it up. I don't have time to look up any poison there is. Okay? But this is how you figure it out. I remember the first time I tried it was they said somebody was hunting in the woods, picked up some mushrooms. Now mushrooms have some chemical called alpha-mannitine in it. And I couldn't remember what the hell alpha-mannitine did. And then after a minute, I said, wait a minute, let me use those three things. And I looked at all the answers, and the answer was messenger RNA. Why? Because the only one that was made in the nucleus. See my point? And that way I get a point and look it up after exam, find out I'm right. Not because I was sure. All I did was go back to basics again. That's why you gotta fight the panic. Because I started panicking again. I was like, oh man, what does afametin do again? I can't remember. All I did was go back to basics again. Okay. I need something with a nucleus, lysosome, mitochondria. I bet you I get a point. Now you've been empowered to do the same thing, folks. Don't panic when they give you some chemical you never heard of. If they say it kills you, now you know how to figure it out. Okay? All right. So smoothie urine. That means if you damage a smoothie urine, you should not die. But it can still overwhelm your system, and that means you can still die from it. This is why companies come along, they send a guy in a $2,000 suit, driving a limousine, and he shows up to your town, let's say with the townspeople, and they want permission to dump some chemicals right outside our town. So we all show up, let's say we're all 30 years old. We all show up to the town's meeting, and they say, you know, we want to dump this chemical right outside your town. We all look at him, no, you ain't dumping no chemicals outside our town. Get out of here. He said, no, don't understand. This chemical, yes, it is toxic, but it only damages your smoothie urine. And if it damages your smoothie urine, you should not die from it. I got a stack of articles right here that shows you don't die from smoothie urine damage. Everybody follow me? He's not lying so far, right? Okay. To make sure nobody ever asks him the question, folks, hardly anybody ever stands up and say, well, if it's that safe, what are you dumping outside your neighborhood then? If you believe in it, and you're trying to convince us, dump it outside your neighborhood. And therefore, you don't have to worry about it either. No. You know what? To make sure nobody asks that question, what they do at the end of their speech, they say, you know, if we can dump this outside your town, it comes with 1,500 blue-collar jobs, paying of $80,000 to $150,000 a year. What? You say jobs? Money? These jobs? What happens when poor people haven't had a job in a long time and you come along and offer them jobs that pay a lot of money? They say, we'll take the job. That's why nobody ever asks, why don't you dump it outside your house? Dump it down the street from your house and your neighborhood. They always offer jobs to go with it. Okay, so let's take the jobs. How do these chemicals gonna work? They're gonna kill the cell. That means the cell is gonna do what? Die or mutate. Everybody follow me? All right, so now, they always put it in the lead drum. Why do they always pick lead? Because lead takes about 20 years to disintegrate. That's the best we have so far. So they always put it in a lead drum. That means it's gonna take 20 years before it even leaks out. So then we're in our 30s, at age 50, it starts leaking out. It gets into our water. And all of a sudden, people are dying in the town and we can't figure out why they're dying. Now we've had children. The children are 20 years old, but they're dying from cancer too. And dying from diseases we cannot explain. Everybody follow me? This is how it happens in the real world. So then somebody starts scratching their head, doggone it, what's going on, man? Why is everybody dying so quickly in this town? Why are our children getting cancer at age 21 and 22? This doesn't make any sense. So somebody say, hey, wait a minute. I wonder if it's that chemical they dumped outside our town 20 years ago. Okay, so you start fishing around. Let's go check things. They check the plants, check the rivers, and all of a sudden, da-da-da-da, chemical! It's that company. It's that company. It's their chemical. Get them back here. They got to stand before us and explain this to us. Folks, what you don't realize is they were waiting for your call. You think you're going to shock them. Nah, they're waiting for your call. But look how long it took for you to figure out what's going on. Let's round it up and just say 25 years. 25 years. And then you call them to the town's meeting again. They show up. They got the stock article still in their hand. What do you guys want? Hey, that chemical that you dumped outside our town, we found it is leaking into our water. And we're drinking it. Our children are drinking it. People are dying for no doggone reason. Our children got cancer and they're dying in their 20s. It is your chemical that leaked out of the barrels. You said, no, our chemical? No. It's not our chemical. No way. You know what it is? I think it's all those McDonald's you got in your town. You guys know you got more McDonald's per capita in this town than most towns? And you know, McDonald's, they fry their foods, and fried food emits nitrites. Nitrites are free radicals. Maybe that's what's killing you guys. Uh-oh. He's right. It's called a confounding variable. It just got thrown in your face. Now you have to prove that he's wrong and that he's lying. Don't worry, they expected you to do that too. So what do? First we run what we call an Ames test. An Ames test is to decide whether a chemical is toxic or carcinogen or not. Let's say it that way. Ames test, you use salmonella. So they'll just ask you what bug is used in this test. If you can make salmonella mutate, you're a carcinogen. That's a simple test. But now you have to embark on a big test and factor out all the other factors that can cause cancer and early death. How about pollution? Smog, fried food, cardiovascular disease? Yeah, right. By the time you factor all that stuff out, you know how long a study like that takes? 20 to 30 years. Now remember, it took you 25 years, so you figure out they lied to you. Then you embark on a study for another 20 to 30 years. Folks, by the time you figure out they've been lying the whole time, you know what percentage of people are still alive? Don't worry, they calculated that too. Only 15%. That's why they settle. You don't have to settle with somebody who's dead, folks. Even though all the town filed a lawsuit, you already know 85% of people will be dead by the time that study's done. All right, so you settle with the other 15%, there it is. And guess what? The chemical's still in your town. You didn't do anything to get back at them. Let's be conservative. Let's say it's a company that makes $10 billion a year off that chemical. Times 55 years. Do the math. That's a hell of a lot of money. You know what the penalty was years ago, about 25, 30 years ago? If you caught a company doing something like that, you know what the penalty was? $25,000. Now tell me you've heard me. If I made 550 million, $5.5 million, well, actually billions of dollars, all right, and then you find me $25,000. I'm not even kidding with this, folks. This was a law from way back, I don't know, 1700s, when there was only like 2 corporations in all of America. So they didn't want a lawsuit to close down the only corporations they had. So they made a law that you can't sue for any more than $25,000. Now back then, that was millions of dollars. But they never changed the law. As America grew, more corporations everywhere, they never changed the law, still $25,000. This is why they said white collar crime pays. It did. Because again, some smart lawyer found out about that and said, man, please do whatever you want. They can only sue you for $25,000. That's it. It's amazing, folks. Okay, so when the politicians found out about it, okay, it was really the papers who found out about it. Politicians were forced to change the law. You know what they changed the law to? You can now sue them for $2 million. Can you tell me again how if I just made $55 billion and you sue me for $2 million, that's actually going to bother me? Right. Again, why they say white collar crime pays. Man, let me tell you something. If you go into the hood and you're selling weed before weed was legal, or you're selling crack cocaine, and they catch you even with a rock, that's $10. They take everything you own. They have a law, takes everything you own. Take your car away from you, your house, your mama's house, your cousin's house. They take the coat off your mama's back, they take everything. Because they say drug money was used to buy that stuff. They do. How come when a company kills millions of people, and that's it, you take $2 million? Look what happens every time a company's caught doing something. Even when it fired a CEO, you guys ever seen some of this in the news? The CEO gets fired. He got a $250 million severance pay. Can you tell me how that hurts him? And how that makes him do something different with the next company he's going to? That's what they do. This rich company. Yet for a drug dealer in the hood, you're going to strip him of everything he owns and everything his family owns for drugs. And yet for the thing that kills millions of people, you're like, no big deal. Oh my goodness, folks, that's the bad part of politics. That's all that editorial just to tell you, you got to vote, folks, because if you don't vote, you've already made a vote. You've already voted for the wrong side. Because somebody's always voting on whether to let things like this happen to you. And if you don't understand it, and you just let this other guy just make decisions that kills people in your family, it affects all of us. It affects your family too. Okay? Because they're making decisions that allows corporations to kill a bunch of people, and that's okay. Okay, and they're worried about drugs in the neighborhood. That makes no sense to me. All right, folks. Labeling proteins, final drill. Pre-sequence, guys, the protein where I be? Interrupt VI, then it's cleaved and destroyed. Pro-sequence, guys, and where I be? No, not pro-sequence. I said, to the Golgi apparatus, the pro-sequence. And who's the chaperone? I said. Okay, Justin. What was the question? We're moving backwards. What is the chaperone for the Golgi apparatus? It just be 90. And the pro-sequence for every protein is then cleaved in the Golgi and destroyed. All except one protein. Who is that? Andy. The only pro-sequence that's not destroyed. What protein is that? Saba. Not collagen. Carrot. Yes, insulin. Remember, it's the C-peptide. Don't forget that, folks. Mannose-6-phosphate label is added to Golgi to guide you to the lysosome. Showing amino terminal sequence added right here to rough yard to guide you ultimately to mitochondria. HFG70 is the chaperone. Any questions on labels? So irreversible cellular death. Let's try Bailey. You go first. You ready? All right, here we go. Irreversible cellular death. There are three things. First one, say it. Nuclear damage. Second one. Lysosomal damage. Third one. Mitochondrial damage. These are the three most important things. Everybody understand? You damage these three things, that cell is not coming back. That means don't do surgery. It's irreversible. Don't do dialysis. Irreversible. Prognosis, not good. Everybody understand that? Well, folks, it occurs in 6 hours in all tissues. Except the brain. That means Bailey. If somebody cuts off the blood supply to any tissue in your body, how long do you have to save that tissue? 6 hours. I cut the blood supply off to your heart. How long to save the heart? 6 hours. That means if I cut off the blood supply to your heart, if I want to have the best prognosis, I need to remove that clot in less than what? 6 hours. That means if you had an MI, when does CPK start to rise? When? 6 hours. Folks, 6 hours is all over the literature, but you guys have never caught on. It's been the same all the time. You got 6 hours for every tissue except the brain. I don't have to look it up. It's the same all the time. 6 hours all the time before it is irreversible. Now remember, ischemic damage starts at 4.5 hours. I didn't say that. Remember, it's two different things I'm talking about here. Ischemic damage, but it's not irreversible yet. So 6 hours. 6 hours, sorry, nothing we can do now. 6 hours. That means if you cut off the blood supply to your leg, baby, how long to save that leg? 6 hours. Let's say you got ovarian torsion. How long to save the ovary? 6 hours. So let's say you got testicular torsion, not your testicles, somebody else's testicles. And how long do you have to save that testicle? 6 hours. Everybody understand? It doesn't matter what tissue we're talking about. The answer is 6 hours, except the brain. How long do we have, Bailey? 20 minutes. So that means, Bailey, listen to me one time. What organ is the most susceptible to ischemic damage? You say what? The brain. What organ is most susceptible to hypoxic damage? You say what? The brain. Anytime somebody's ischemic or hypoxic, what organ you worried about? Bailey, you say what? The brain. Anytime you don't know what's going on with somebody, what organ you worried about? The brain. I mean, somebody's down on the ground. What organ you worried about? Bailey. The brain. Somebody's upside down in the water. What organ you worried about? The brain. They're standing in the water. What organ you worried about? The brain. They're swimming in the water. What organ you worried about? The brain. Does everyone understand why it's always the brain? Always the brain. Don't ever change your answer. I don't care what any book said, folks. If you change it, good luck to you. Okay? Because that answer has never changed. This is why if you're having a seizure continuously, what organ are you worried about? The brain. How long do you have to save that brain? 20 minutes. Why do you think it's called status epilepticus after 20 minutes? Look up ACLS. Why do they tell you if there's no pulse after 20 minutes, stop the CPR? 20 minutes throughout the whole literature. How come most doctors don't ever see it? Everybody's still guessing. Now realizing it's been the same number the whole time. It's always been 20 minutes because your brain is dead in 20 minutes. That's why they say if you haven't had a pulse in 20 minutes, you might stop. The brain. Who cares if you restart the heart? When I was a resident, we'd be working on people for an hour and a half. And then the heart would start back up. We get all happy. Forgetting the patient's dead already. He's brain dead. All you did was bring a dead body back to life, get the heart started back up, put the person in the ICU and run up $300,000 in the next 24 to 48 hours. Till a study came out and said, good Lord, 75%, this was an AARP study on elderly people. It said 75% of healthcare dollars spent on elderly people were spent in the final 72 hours. Can you believe it? That's because doctors did not want to let a dead body go. They thought, no, let's start the heart. Nobody told them, once the brain is dead, what are you doing? Now we know, 20 minutes, folks, stop. 20 minutes, stop, no pause. They died already. Okay, they died already. 20 minutes is all you got. Yes.
So like, no matter how many compressions and how many breaths you do, there's
Doesn't matter how many compressions, how many breaths you do. If they have not had a pulse on their own, after 20 minutes, you stop CPR. They're gone. Wait a minute, I got a question for you, Bailey. What is the most common cause of cellular death? That's unexpected. Necrosis. What's the most common cause of necrosis? Ischemia. So what's the most common cause of all these changes I'm talking about? Ischemia. Wait a minute. If you have ischemia or damage to the cell in any way, Amy, what's the first thing that stops working within that cell? Not the nucleus. Back to Bailey. What's the first thing that stops working? Sodium, potassium, ATPase is the first thing that stops at all times. If that thing stops working, Bailey, who gets trapped within the cell? Sodium. Sodium gets trapped within the cell. Will the cell become more positive or more negative? More positive. Is it going to be more or less likely depolarized? More likely or less likely polarized? Remember, depolarization is to become positive. I just told you to become positive. That means it's now more likely depolarized. You understand that? So that means what's the most common cause of a cell more likely polarized? Bailey says what? Sodium potassium pump stopping. What's the most common cause of sodium potassium pump stopping? Cell damage. What's the most common cause of cellular damage? Ischemia. So what's the most common cause of spontaneous depolarization? You say what? Steve, what's the most common cause of cells who want to depolarize? Steve, most common cause is what? Steve, what's the most common cause of cells in your body depolarize for no doggone reason? So we say what? The most common reason for any cell in your body depolarize, you say what? Steve, what's the most common cause of any cell depolarize in your body? Say what? Everybody hear that? Everybody hear that? But you didn't hear what you just learned. Hey, what's the most common cause of seizures? You say what? What's the most common cause of cramps? You say what? What's the most common cause of arrhythmia? You say what? What's the most common cause of diarrhea? You say what? What's the most common cause of seizures on the right side of your brain? Most common cause of seizures. I was about to say diarrhea in the brain. Damn. That would have sounded crazy. Okay. What's the most common cause of depolarized sensation in the left side of your brain? What's the most common cause of generalized seizures? Excuse me. What's the most common cause of absence seizures? Excuse me. What's the most common cause of mixed and myotonic seizures? Yeah. What's the most common cause of intestinal spasms? And what's the most common cause of febrile seizures? Look it up. See if I'm messing up anywhere. Look it up. This is the scam they've been running on you guys. They make you think it's different all the time. It's been the same all the time. But when physicians don't know that, they think the answer is different. And then that's how you change your answer and you got it wrong. Ischemia is the most common cause of every spontaneous depolarization in the rest. That means, baby, if you want to stop a seizure, what's the first thing you ought to give the patient? No. What's the first thing you ought to give the patient if ischemia is the most common cause of that seizure? Not a vasodilator. Let's see what Steve said. Oxygen. It's called oxygen. So the most common treatment, the best treatment for any seizure, Steve, is what? You got absence seizures. First thing you ought to give them. Oxygen. You got temporal lobe seizure. First thing you ought to give them. Oxygen. You get partial seizures. First thing you ought to give them. Oxygen, folks. When somebody's in the ER, first thing we ought to give them. Oxygen. Anytime somebody's down on the ground, first thing you ought to give them. Why is it that the paramedics are told put oxygen in everybody's face before you figure out what the hell is going on? I've had 3 paramedics come here and they finally understood why that was the protocol. But before that, they just knew it was a protocol written on a piece of paper right up here. Oh, always give the patient oxygen before you work out why they're down on the ground. Folks, because ischemia is the most common cause why the patient's down on the ground. That's why. Now you know. So the first sign of inflammation due to everything, now you know. The most common cause of every spontaneous depolarization, now you know. The most common cause of every seizure, now you know. What's the most common cause of arrhythmia, Maria? Most common cause of arrhythmia. What? Ischemia. Folks, the most common cause of every deposition is ischemia. It's just that on the test, they change the names around and you guys don't catch it. See, on one test, yours will say an MI. Doesn't that cause ischemia? On your test, they call it pulmonary embolism. Doesn't that cause ischemia? On your test, they call it mitral stenosis. Doesn't that cause ischemia? That's what I'm telling you, folks. Don't start memorizing a bunch of words. On the test, just say, I need something called ischemia. And then you'll see there's only one. There's only one. Instead of memorizing first day, say 3 things. Oh, no, don't do that. No, you only know 3 things, and that's it. That's why I know there's 1,000 more after that. Okay, because a lot of things cause ischemia. The most common cause of every spontaneous deposition is ischemia. I'm not changing my mind for anybody, because that's never been the wrong answer. That's what I'm telling you. There's never been the wrong answer. All I do is just say, well, which one causes ischemia? Oh, good, only one. It's a free point. You understand that, Miguel? I don't know. Let me try it one more time. You understand that, Edna? You understand it? Really? Oh, no, let's try you then. What's the most common cause of spontaneous deposition? Ischemia. What's the most common cause of seizures? Ischemia. What's the most common cause of muscle spasm? Ischemia. Most common cause of diarrhea? What's the common cause of blepharospasm? What's the common cause of seizure right behind your ear? Ischemia. Most common cause of arrhythmias? Ischemia. Most common cause of spontaneous depositions in the heart is what? What's the common cause of arrhythmia again is what? Most common cause of PSVT is what? What's the common cause of multifocal atrial tachycardia with 2 to 1 block is what? What's the most common cause of AFib? You say what? Most common cause of atrial fibrillation, you say what? What's the most common cause of atrial you say what? How about PSVT? You say what? How about VFib? You say what? How about VTAC? You say what? How about Torsade de Pointes? You say what? Look it up and see if I missed anything. Thank you very much. I told you if you want to blow an attending's pants off, this is something that most attendants have never been taught. If you look in your book right now, first aid, you know, atrial fibrillation, they put hyperthyroidism, pheochromocytoma. Yeah, so what? You know 2 things, that's it? Oh, that's why I was way ahead of you, that's all you knew. See, that's the problem. When students are not taught the right thing, they think the 1 or 2 things the book says, that must be all I need to know. The book never taught you the lowest common denominator. Teach it to me down here. Then the test writer can play all the games he wants, and I can still figure it out, okay? And that way, the attending on the teaching rounds can fire off any arrhythmia, and I just keep saying ischemia, because I know I'm right. I don't have to hesitate, because I know I'm right. But sometimes he doesn't know I'm right. And so if he doesn't know I'm right, he challenges me. What I do? I talk out everything I just told you right now. All of a sudden he realizes, oh, damn, it is right. All of a sudden he realizes he only knew what the book said, but he never knew ischemia is still the lowest common denominator. Anything that causes ischemia is number 1. The number 1 reason why people end up in the hospital, Hannah's what? Ischemia. That means the first thing you gotta give to somebody who comes to the hospital is what? Oxygen. This is why when you walk through a hospital, you can go to the emergency room. You just say, hey, ma'am, can I put oxygen in your face already? Like, wait a minute. I'm trying to figure out what's the cafeteria. Oh, sorry, give me back my oxygen. Yeah, go down the hallway, hey, hang on, left, it should be there. As soon as they roll you in the ER, they put oxygen in your face before they even ask your name. Now you know why. Paramedics put oxygen in everybody's face. Now you know why. It also tells you, Miriam, if somebody's having an arrhythmia, the first thing you ought to give them is what? Oxygen. It ain't lidocaine like the book told you guys. It ain't Brafamil like the book told you guys. For everybody who tries to tell me, but the book says, Dr. Francis, you're wrong. I said, okay, well, you pick your answer, I'll pick mine. Let's see who gets it right. That's what I'm telling you, folks. There's a lot written in the books that's incorrect. Imagine I come out of nowhere and I'm trying to tell you a lot of books are wrong. They would have looked at me like I was crazy. How the hell you know every book is wrong? They would have challenged me all over the country. Said, no, this guy doesn't know what he's talking about. I said, fine, let me show them that so much is misleading in every book that doctors are not being taught the right information. They're being taught details. And then over time, when they saw the high scores that came out of Champaign every month, reliably, that's when they started to realize, okay, I'm getting calls from deans all over the country. Man, what do you do down there in Champaign? They're trying to figure out, is there a book I need to tell my students about? I said, no, there's no book. I said, if your students are having trouble, put them in front of me. I'll teach them the information. I teach them how to think. And there's always a little pause in the phone because they're trying to figure out, what the hell does that mean? You teach them how to think? They don't know what that means. Because they thought, well, you just teach what's in the book. I said, well, they can read the book on their own. They don't need me to do that. It's just a bunch of detail. What I'm gonna do is teach you how that stuff was obtained. And when you obtain it yourself anytime you want. Instead of trying to remember what the book said, pull it out of your own mind. And therefore you can shine in front of anybody. I mean, just like Cassandra this morning telling you. As soon as she got into residency, how come she's outshining all the other residents who've been there for years? How come she understands it better than they do? That's because they're trying to remember what did the book say about this, and she can figure it out just like this, because she knows the pattern to it, and they didn't. Okay, or my student being chosen to be on CNN to describe all the complications of COVID, because the infectious disease expert didn't know it. He didn't know that you don't have to wait for a study to tell you what it is. You can figure it out on your own. So they chose somebody who's not even infectious disease expert. And she's on CNN, national TV, talking about all the effects of COVID. And infectious disease experts are at home watching the damn TV instead. Because they didn't know the answers. So they felt uncomfortable going on TV and guess. See, memorization, memorization, memorization all the time. Same thing I've been saying for years. That's what's going on around medicine. Everybody's memorizing everything. Thinking that if you memorize enough, oh yeah, you pass the exam. No, you won't. Because the test writer will blow you away some more details you still don't understand. And so you're gonna pick a new answer, but your answer's wrong now. So folks, it's amazing. The brain is your most precious organ. Don't ever forget that. Most sensitive to ischemic damage. Most sensitive to hypoxic damage. When there is cellular damage, sodium potassium pump stops first. Sodium gets trapped inside the cell. The cell becomes more positive. Cells are now more like depolarized. And therefore, the most common cause of depolarization is cellular damage. Sodium potassium pump has to stop. Ischemia is therefore the most common cause of cellular damage. So ischemia is the most common cause of all spontaneous depolarizations, no exception to the rule. Don't talk yourself into anything new. Just say ischemia and then say which answer matches ischemia, and you'll see your answer. Okay? All right. You know what that means? Ischemia is the most common cause of, look at that, seizures, cramps, muscle spasms, blood spasms, arrhythmias, anything that's called a depolarization. You just learn how to cause it without ever having to read about it again. All right. After sodium is trapped within the cell, chloride will follow inside. Water will follow both of them. Swelling is therefore the first visible sign of every acute disease. That means you never have to look up the first visible sign of any disease. Any. It's never been wrong. Never been wrong. That means if you finally find one, whew, boy, you just discovered something brand new. That's the one rare disease. And if that makes you happy to be right one time out of millions, good luck to you then. Go ahead and pick that one. But I'm picking this answer all the time because it's rarely ever wrong. I mean, every now and then they'll catch me on some rare disease I never heard of. That's okay. Now, after sodium is trapped within the cell, look at this. You lose a gradient for the sodium calcium exchange. This means now calcium is trapped inside the cell. Well, there's a drug out there that blocks the sodium potassium pump, Chris. That is called digitalis. That's the water soluble version. Digoxin, the fat soluble version. And then Wabane, that's what we use in the lab. Look at that. This is how they cause increased contractility because you're trapping calcium inside the cell. See, that way you don't have to look up. How does DIG work again? Now you know how to talk it through it, figure it out yourself. The problem, however, if it's calcium trapped inside the cytoplasmic cell, Justin, you see a problem with that? What problem do you see, Justin? Gonna bind a lysosome, destroy the lysosome, destroy your nucleus, destroy you. So whereas, folks, digitalis increased contractility, I can also tell you why digitalis kills most people. Look up in the literature now, see if I made it up. But that's something I could see 28 years ago. I said, yeah, you're telling me dig saves lives. No, it saves symptoms. It increases contractility so you feel better. So we still use it. But every study they have done with DIG in it, you don't live very long. I said, hey, I'm not surprised. Look at what your drug is doing. It's trapping calcium inside the cell. Yes, you feel better for the moment, but you're gonna die real soon from it. Real soon doesn't mean a year or two from now. You'll live for a while. But when they do it, age match group, what happened? Your group dies quicker than the other ones. That means DIG is killing you. And because now cardiologists are finally starting to understand this, why do you think we're doing more procedures now? Because we realize the drugs will eventually kill people. I'm telling you, this is a new finding to cardiologists, that all the drugs we give mostly kill in the long run. Because all this time they thought all these drugs would save lives. But based on the mechanism, you can already tell they're not going to save lives. They save lives for now. You may live a couple more years, but after a while, my drug will kill you. And that's what they found. Every study with DIG, they did DIG alone, DIG with diuretics, DIDs with dopamine, DIDs with any of the, every time DIDs in there, no, you die faster. Now you know why. Simply because of the action. Okay? All right. This is how those work, but look at this is why dying cells calcify, that's what I pointed out to you. So you know what dystrophic calcification is, and you have a hypercalcemia, same thing will happen, except calcium is leaking in down the gradient. Now you know what metastatic calcification is, Nolan? Is nuclear degradation, actually kills the cell. Exactly. No, swelling and lysis starts to damage the cell. The actual death of the cell is when the nucleus gets destroyed. Yes, remember, it has to be nucleus, lysosome, or mitochondrial damage for the cell to actually die. This is why chronic disease leads to calcification. You ever wonder why your aorta calcifies as you age? Want to know more? How come granulomas calcify as you age? Want to know more? Simply because any chronic disease starts to steal your energy away from you. Just like Nolan recognized, any low energy state will lead to the same effects. Because now the sodium potassium ATP doesn't have enough ATP. Same thing. That's why all of us, as we age, we will calcify. Never have to doubt it, okay? All right, apply this knowledge to management. Look at this. The first treatment for seizure is given what? A B, oxygen, not phenytoin, not ethosuximide. See my point? Who wants all the drugs in the book? The drug companies. Folks, they got permission from the government a long time. I told you better get involved in voting because they got permission from government a long time ago to have their drugs put into the book. They say if the doctor figures out all this stuff, great. But if the book always mentions a drug, every doc swears what the drug the book said is the answer. And they wonder why doctors are mistreating physicians. I mean, sorry, mistreating patients. These many years later, that's because now doctors just read and memorize books. They're not even encouraged to think. If you question, they look at you like, why you even asking a question? All of a sudden now residents can't ask questions, students can't ask questions. So every doctor swears whatever the book said must be the answer. And that's why we're mismanaging patients. Okay? First treatment for seizure, give them oxygen. First treatment for arrhythmia, same thing, give them oxygen, folks. See that? First treatment for cramps, that's why I give them oxygen. First treatment for all arrhythmias, give them oxygen. Before the drug, give oxygen. All right? This way you don't have to look up any of these depositions. The answer is the same for all of them. The first treatment for anyone who's sick, folks, is the same thing again. Give them oxygen. Been empowered. Everybody understand? Any questions at all? Yes.
Going back to the pain, I've seen some patients at the hospital after trauma when they are pain them, they still keep them for like a year or two for the orphan.
Yeah, patients, and he said he see patients in the ICU who are brain dead, and they still treat them in the ICU for several days. They found, folks, the big problem was doctors found it hard to let somebody go ahead and die. I'm serious. But the patient died 2 days ago. We just keep the corpse alive. I told you, they taught us, keep doing CPR, get the rhythm back. They never said 20 minutes stop.
They say like, they put the note, this patient is being dead.
Yeah.
They say like, oh, we are waiting for the orphan.
Yeah, now that's different. If you're waiting for a transplant surgeon to come and harvest all the organs, that's what we do. We keep the body alive till she or he can harvest all the organs. Yeah, but when somebody is brain dead, it's time to let them go. You have to. I mean, legally, you can now tell the patient's family, your mother is brain dead. And we'll talk about the criteria at a different time. Yes. Is there a patient that's been saved from what? When somebody's brain dead? No. Well, on the way to it, it's still reversible. Well, once you're brain dead, that's it. There is no coming back. Yeah. It's just that doctors thought, well, if you get the heart beating again, maybe they'll come back. No, the brain is the most important organ. Once it goes, that's it, we're done. It's just that physicians didn't understand that. They thought, start the heart back up. No, the body's still dead. The patient's body's dead. There's not much you can do with it. Ashley. All right, she's gonna ask me a 10% question. Here it goes. What about locked-in syndrome? They're not brain dead though. No, locked-in syndrome is not brain dead. Yeah. Brain dead, I mean, a locked-in syndrome can still respond to you, but remember, just be blinking their eyes. That's it. Yeah, they can blink. Oh, yeah. Blink one for yes, two for no. That's responding. They're alive. Yeah, that's different. Brain dead does nothing, folks, does nothing. And a later time, I'll go through the criteria for you. Once you prove somebody's brain dead, you can pull a plug. You don't even have to put it in the patient's family's lap. The patient's family said they don't want doctors asking them permission to pull a plug. They want you to tell them, grandma is dead. It meets the criteria for brain death. We cannot bring her back. We're gonna keep her comfortable in transition. They just wanna know you're gonna keep grandma comfortable and let her go to heaven. You don't have to ask them, hey, can we pull a plug on grandma? You know how crazy that sounds? What do you mean pull a plug on grandma? I'm not gonna pull a plug on grandma. Guess what? You now have a legal battle on your hands because you asked them. Once you ask them and they say no, you cannot pull a plug. Now you're gonna spend hundreds of thousands of dollars in court to get permission to pull a plug. And you're the one paying the bill because they're not gonna pay the bill. And you can't make them.
I don't know what.
How does that work? Anyway, there's been many cases. They'll just file bankruptcy. That means the hospital's stuck with the bill. That's what they do. Yeah. So that's the thing is you don't want to get into a legal battle. And that's why they made it. The best way is to tell people, here's what we're gonna do because grandma is brain dead or your mother's brain dead. I mean, that, folks, anytime I've done that with a family, I've never had any family say, no, don't pull the plug. It all depends on how you deliver the information. Why do you think there's so many more questions about how to deliver bad news to people? Because if you deliver properly, they will agree with you because they trust you. I remember my first mentor, Dr. Rick, he said, our job as doctors, we don't decide who lives or dies. Okay, that's God's job. However, our job is to keep people healthy while they're alive and keep them comfortable as they die. This is a guy who I trust and respect, and he's telling me this is our job. We don't decide who dies. So that means you don't dump it into somebody's lap and make them decide when to make grandma die. Don't do that to people. They just want you be the doctor. You tell them exactly what's going on and let them know. There's not much we can do. And then they'll trust you. As long as you say it the right way, yes.
But the logins,
Yeah.
for the rehab part, we teach them to 5 to 6 commands, just using their.
Yeah, just using their eyes. Yeah, this man is a physical therapist, so he's telling you his own experience with locked-in syndrome. You know, they can teach him all kinds of commands with the blinking as the answer. Yeah, so that's somebody who's not brain dead because they can answer you. Okay. All right, folks, let me, Isis, you have a question? Isis? Okay, change their mind. All right, let me start membrane physiology and then we'll just continue in the morning. Because membrane physiology connects right to what we just talked about.
Excuse me.
All right, Mabel?
Yeah,
Okay,
please,
you're next. Go ahead.
Yeah, please, what is the mechanism of action of digitalis?
Digitalis blocks the sodium potassium pump. Now, that's a good question. I just realized I didn't tell you guys. Digitalis, digoxin, it blocks the sodium potassium pump by competing with potassium. So it competes only with the potassium side, not the sodium side, because you got two sides to that pump. You understand, Mabel?
Yes, sir. Thank you.
All right, Matt?
How does the calcium damage lysosomes?
Calcium, how does calcium damage a lysosome? Calcium sits on the surface of the lysosome, causes detergent damage. That means it destroys all the charges, and then that means water can come on in, and the lysosome will swell up and release all those enzymes. And those enzymes will then go and attack your nucleus, and then you die. Any other questions before I begin the next topic? All right, membrane physiology connects right. Let me get some new batteries in this thing. All right, there we go, fresh batteries. So membrane physiology connects right into cellular physiology. Notice I only talked about what's on the membrane. Now we're gonna focus on just the membrane. We've done the cell organelles that are inside. I didn't really talk about everything the membrane can do, and that's what we're gonna do now. What can the membrane do? Here's what it does. Number one, provide shape. Nobody knows that better than a pathologist. That's what he does for a living. Look underneath the microscope and he sees squamous cells. If he sees squamous cells, he said they must have come from someplace where there's a lot of abrasion. Squamous cells are meant for handling trauma and abrasion. See? Columnar or cuboidal cells are made for glandular. And then transitional cells only found in the uterine bladder. Just a quick histology. Okay, so provide shape. All membranes are said to be amphipathic. What's that mean? Come from the word, Gustavo, for amphibian. That means laying in water, right? Amphibian. You do laying in water. For physiology, it's fat soluble and water soluble. And Gustavo remembers that when you have a protein, fat soluble wants to fold to the inside or outside, Gustavo? Fat soluble wants to fold to the inside away from water. Right, Anders? And then water soluble wants to fold to the outside in contact with water. And then if you got two sulfurs next to each other, there's something bond. A positive and negative, covalent bond. Okay, but you got to satisfy this first. Fat soluble inside, water soluble outside. That means, Anders, what is it that water hates more than anything else? Fat. What is it fat hates more than anything else, Karina? Water. Anders, what does fat love more than anything else? Fat. What does water love more than anything else? Water. You understand that? Anybody not understand that? Okay. Let's say you're cooking a pot of soup and you put a drop of oil in that pot. The oil is fat soluble, right? But the pot of water is water soluble. Everybody with me so far? Has anybody noticed that that drop of oil will start dancing around the pot like this? You know why it's doing that? Because it hates water. It's like, oh, water. Water. Hey, brother, water. Yeah, what am I gonna do? What am I gonna do? What am I gonna do? That's it. That's why, as long as that pot is boiling, that drop of oil will keep dancing on the surface of that water. He's trying to run away. What if I put 2 drops in there? Do you notice the 2 drops will start dancing around the whole pot until what? They find each other. So he said, water. Ooh, some fat. And they go, ooh, hey, glad to meet you, man. Ooh, your sister? Hey, what's up? And they will find each other, and what do they do? Rise above the water. That's why the fat always clumps up to the top again. Let's say Anderson, Dr. Fancy, I saw oil and fat mixed last night. I'm cooking some soup. Fat water mix? Folks, that's called an illusion. The fat water never mix. But you can break the bonds. So what happens when you boil a pot hot enough? You now break the bond of the oil. Everybody follow me? That's why then it kind of dissolves in the pot like this. That's why you can then stir it in. It looks like they're mixed. What happens when you leave the pot on the stove, take it off the hot one, put it on the cold one? You don't have heat to break those bonds anymore. Fat comes right back to the top and says, ooh, food's that would have never mixed. They give you the illusion that they're mixed, but they're not mixed. Okay? You gotta heat it up to a point where you break the bonds, so that way it looks like they're actually mixing, but they're not mixing. Everybody understand that? So Angie, the one thing fat loves is what? Fat. The one thing water loves is what? Water. The one thing fat hates is what? Water. The one thing water hates is what? Fat. So that means, Jess, if I look at a part of your body that has a high fat content, what does that tell me about the water content? Low. Everybody understand that? Let's look at your brain. Marlon, your brain is 95% fat. Your blood is 95% water. What does that tell you about the blood flow through the brain? Just says. High or low? Low. And everybody therefore tell me why meningitis is such a deadly disease? Because blood flow ain't coming anytime soon. Why do you think you have a window period? They say start antibiotics as quick as you can. Because whenever you have meningitis, the meninges actually open up like that. You want to get the antibiotics in there quickly while the germs are in there. Because if you wait and the body tightens back up, your antibiotics over here, the germs over there killing your patient. Because your body always repairs everything. Yeah. So you have a window period when you have meningitis. And if you don't get the antibiotics into that brain during the time the meninges are open, your patient's going to die. Or in the least, severely brain damaged. Now you know why. Now, That tells me therefore that any part of your body with a whole lot of adipose, does everybody understand, is gonna have very little blood flow. You understand, Armando? You understand that, Miguel? Understand that, Karina? You understand that, Mabel?
Yes, sir. My
All
mind
right.
free.
Do you understand that, Tommy? Tommy, you there? How about Peter? You understand that, Peter? Mamita, do you understand that?
Yes,
Peter.
sir.
Your mic is not working. I didn't hear you. Okay,
I got it.
all right, there we go. Now I can hear you. Carly, do you understand that?
Yes, sir.
All right. Ryan Ford, you understand that?
Yes, sir.
All right. So anywhere there's a whole lot of adipose, what's that tell you about the blood supply, Ryan? Higher or
Blood
lower?
supply,
What's that?
blood supply would be low.
There's gonna be less supply. Everybody understand that? That means anywhere in your body where there's a high fat content, does everybody understand? You got low blood supply. And therefore, it's poor prognosis. Does everybody understand why? That way you don't have to look up meningitis to see why it's poor prognosis. That way you don't have to look up mastitis, the breast is 95% fat. Why do you think that's poor prognosis? If you let that infection set in, you're in trouble. How about paniculitis, midsection fat? Why do you think that's bad? How about umphalitis, a newborn baby, fat, right here? Why do you think they say put them in the hospital? That's because we don't want to take the chances. Poor prognosis, folks, because blood flow is not going to just come in readily because it's going to be repelled by the fat, which means that infection could kill the person. You understand that now, Rakia?
Roger, sir.
All right, Susanna Hall, you understand?
Yes, sir.
All right, Ella Sheba, you with me?
Yes, I am.
All right, check this out then. Now you know why obesity is a risk factor for infection in the hospital. Now you know why obesity is a risk factor for mortality in the hospital. Look it up, see if I messed up. Now you know why obesity is a risk factor for infections in the ICU and mortality in the ICU. Look it up. I didn't mess up. It's the same thing. Okay, this is why before you do surgery on somebody who's overweight, why do you think surgeons have a habit of saying, why don't we get you to lose some weight? Then I'll do the surgery. But if they don't explain it to the person why they ask them to lose weight, the person gets mad because the surgeon told me I was too fat. And see, then I'm the resident. He said, Francis, you go fix it. He just went in there, just so the person said it the wrong way. The person's pissed off now because the surgeon said I'm too fat. Because that's all the person heard. And then I got to go in there and then straighten it out and explain. That's not what he meant. He means that you just need a hernia surgery. That's a simple surgery. However, he has to cut through a lot of fat to get to that skin or that layer of tissue. But that means that layer of fat that he has to cut through needs time to heal. And your blood is 95% water. It's not going to go in there too easily. That means what you think is a simple surgery with a simple infection can turn into significant sepsis and kill you. So the surgeon's really looking out for your welfare. So he's saying, why don't we get you to lose some weight and then we'll do the surgery. So let's talk about how we want to get that done. See? Without, that way you do it respectfully. You do it in a way where it sounds like you're advocating for the patient and they don't stomp off saying that you said, oh, I'm too fat. No, but if you explain why you're doing that, then they don't get the wrong message. Okay? And I want you guys to understand why. Okay? But that's why obesity is on the list for all these risk factors. But they don't explain that. They just tell you, oh yeah, risk factor for infection, risk factor for this, risk factor for this. This is why. Okay? All right, so that's fat and water soluble. So here's the cell membrane. So that means anything that's fat soluble wants to be inside, and there's water soluble wants to be outside. So let's say, for instance, Karis, this pen is the receptor. Here's the membrane. And I say, well, here's the receptor. You got to know that there's a piece of it that's in the membrane. There's a piece of it sticking outside the membrane. You ready with me? Where would I find glucose in this receptor? Karis says? Huh? There's no middle. It's either inside the membrane or outside the membrane. You only got two choices. Where do I find glucose? Why inside? So as charged particles go into the fat layer? Wait a minute, I gave you two choices. Inside the membrane or outside the membrane is what I just described to you. You're either inside the membrane, and I said here, or outside the membrane. A receptor doesn't go into the cell, it sticks into the membrane. That means if I ask you where glucose is, you say, well, it's gotta be the part in contact with water. It's out here, sticking out. If I ask you, where do you find valine? See, by being specific like that, you swear, oh my God, I'm supposed to know what amino acid goes with every receptor now? That's the disguise. Where do you find valine? Well, valine's neutral, fat soluble. Oh, okay, inside the membrane. See that? Now I've seen questions like that many times. They make it sound like it's about, you gotta know the amino acid sequence for a receptor. No, you don't. That's what I mean by that. That's why I can disguise a good question with a good detail, so that your mind goes off on a detail and never come back to answer their question. Because you're busy trying to answer it based on valine, not, it's just, oh, is it fat or water soluble? There it is. Any questions on that? So, inside the membrane, fat soluble. Outside the membrane, water soluble. Very follow? Okay. But the one they like to ask about is right here. Channels. You're a channel. So here's a channel. You guys see my hand? The channel. Let's say this is a sodium channel. If you got a sodium channel, the sodium has to go through that channel. Does it not? Is that Halima? Is sodium fat or water soluble? Sodium, fat or water soluble, Halima? Water soluble. Now you have to say water soluble is inside the channel. Fat soluble is outside the channel. That's because the fat is sitting on it like this. The reason why I'm showing you this, so you don't just memorize in, out. Students have a tendency to just want to memorize things without, if you lose that understanding, now you're just in, out. You're gonna miss a lot of questions again. Because this is their favorite one, because you have to think about it. If this is a channel, then the water soluble element is trying to go through the channel. That means water soluble is inside the channel now. Fat soluble is outside the channel. See, on top of it like this, because this is inside the membrane. Okay, so that means if I ask you, where would you find valine in a sodium channel? Amy. Why inside? The question is, where would you find valine in a sodium channel? Inside or outside the channel? Why? Well, how do you know it's inside? Prove it. What? Is valine water soluble? Is valine neutral or charged? No, valine is neutral. So you got to first think about the amino acid that they're using. Valine is neutral, which means it's fat soluble. That means it's going to be outside the channel. If I ask you where's lysine, lysine is charged. Water soluble. Okay, it's going to be inside the channel. See? You got to think it through. Please don't just memorize in, out. Because then they'll use a channel and now you say in the wrong way, out the wrong way. You don't realize you're missing all the questions. This is their favorite one. This is what I remember on my exam. I still see these questions. All right. So very important. Let's look at facts.
Excuse sir.
Just sit back and just listen to the conversation.
I gotta go pee first.
Oh, Lord. Okay. Now you guys know why I'm paranoid up here. Oh man. I keep telling you, somebody's gonna say something they're gonna be so embarrassed about when they find out everybody heard it.
Excuse sir.
Hang on. Let me just mute everybody first. Okay, now you go ahead and speak. Mabel?
Sir, please, I don't understand how you were demonstrating this thing with your hands inside, outside the membrane. I didn't really get it, please.
All right, hang on. Let me zoom in for you.
Okay, sir.
All right, let's do this. Yeah, there we go. All right, this is a sodium channel. You see it?
Yes,
You got
sir.
the hole. That means the sodium has to go through here. You follow?
Yes, sir.
Okay, that means anything that's water soluble, you have to say inside the channel. Anything that's fat soluble, you have to say outside the channel because it's sitting on top of it like this. So the two examples I asked, where would you find valine? You have to think for a second. Valine is fat soluble. You say, well, it'll be outside the channel then. Then I asked about lysine. Then you have to think, well, lysine is water soluble. Okay, it'll be inside the channel. That's how they make it look so specific that when you don't realize it's not really a specific question, you just have, it's all about this same thing right here. Whether you're fat or water soluble is how you decide to answer the question. Any questions on that?
No.
All right. Okay. All right. People online, drill for you guys. Nobody move. Everybody listen to these drills now. All right, this time is your time. Last time it was the people in here. All right, Mamita, you there?
Yes, sir.
All right, what amino acid causes kinks and bends?
Proline.
Proline, Carly, disulfide bonds. Carly Haas, you got to answer.
Sorry, I'm not sure.
All right, Mabel, disulfide bonds, what amino acid? Ayushi,
Cysteine.
cysteine. How about, I need an enzyme that blocks carbonic anhydrase, Idonis. I need a drug that blocks carbonic anhydrase, sorry. Idonis, not there.
I'm not, like a drug or,
I need a drug that blocks carbonic anhydrase.
I'm not,
All right, Peter,
Dr. Google said it's acetazolamide.
oh, don't be doing no Dr. Google when I'm asking you guys questions. Now remember, this is so you guys can learn. Just reading me off of Google is not helping. All right, so don't do that. No, for the rest of you, please don't do that. Because that doesn't teach you anything. I mean, reading to me does not help you. All right, I need a radium enzyme for glycolysis. Hendrik. Ryan Ford,
PFK.
BFK1, radium enzyme for gluconeogenesis. Eric.
No, shoot, you asked me the pathway. I don't know, Dr. Francis.
Okay, Bryce.
Sorry, pyruvate carboxylase.
Pyruvate carboxylase is correct. Radium enzyme for Krebs cycle. Ayushi. All right, Rakia. And Susanna.
Isocitrate dehydrogenase.
Isocitrate dehydrogenase, well done. Purine synthesis, Elishiba. Syed,
I forget the full name, but it's like HPGRT.
HGPRT is for the salvage pathway, so I guess I can't argue about that. But the de novo pathway, remember, is PRPP synthetase.
Okay.
Yeah, that's, but on the test, I'm sure they'll label it, so no problem. All right, radium enzyme for fatty acid synthesis. Acuna.
Is a CP. Oh, sorry.
The question went to Acuna.
Is it CPS?
Oh, I see. Her last name sounds like Acuna. That's why.
Yeah,
All
I'm
right.
sorry.
All right. So which one did you say, Acuna? Remember, it's called acetyl-CoA carboxylase. Radium enzyme for urea cycle. Veronica Acuna.
That's CPS1.
CPS1. And give me a disease that has cherry red macula. Leslie. Give me all three of them. Not there. Latoria. Cherry red macula.
Tay-Sachs is one of them.
Tay-Sachs is one of them. All right, Elizabeth, give me another one.
Would it be Niemann-Pick and
Niemann-Pick is correct.
Sandhoff?
You know them, Sandhoff, very good, that's all three. Give me the disease that has early myofascial leg. It's Sandhoff, Niemann-Pick, Tay-Sachs. All this stuff is in your notes. Stop writing this stuff down. It's all in your notes already. Okay. All right, Aisha, early myofascial legs. What disease has that? And Andy.
I'm not sure, sir.
All right, Elizabeth.
Did you pass me already?
What?
Did you call my name Aisha or the other
Yeah,
Aisha?
I called you earlier.
Oh, okay.
Yeah. You know the answer to this question? Early
Isn't
morning
it-
flash legs?
Isn't it Gauchers?
Yeah, that's Gaucher's. How about, what's the word? Course? No. No, yeah. All of a sudden, if somebody, elderly person says his hat doesn't fit anymore and he's had hearing loss for a while. What disease am I talking about? Jolita, what disease is that?
Acromegalia?
No, not acromegaly. The hearing loss doesn't go with acromegaly. Let's try Hendrick.
Is it Pages?
There you go. Paget's disease of the bone. Remember, I told you my head doesn't fit anymore. It goes with acromegaly and Paget's, but hearing loss goes with Paget's, not with acromegaly. If you're doing acromegaly, they would give you hyperglycemia. All right? They'll give you clues to everything. All right. Any questions, folks? But that's the way we're going to be drilling as we go, folks. You got to know your clues. Everything's in your notes. I'm not asking you anything I haven't taught you already. It's in the notes. So don't write it down. It's already in your notes. You can study later if you want. But just listen so you hear the clue, the disease, the clue, the disease, or drug. And after a while, it becomes so linked together. Every time you hear one, the brain immediately tells you the other. Okay? All right. See you tomorrow morning. We'll continue our journey.